Good afternoon. I think this is the first session in the hall day. So we are So before we start the session, this is a session on arthroscopy. And this arthroscopy has to do the involving branch and going leaps and bounds. And to start the session, I would like to welcome the chairpersons, Professor Rakesh Chaudhary, Dr. Boacon, Professor N.K. Singh, probably is in all day at present. So the next one, Dr. Sunil Kumar, Dr. Kanya Singh is not there. Dr. Madhusudan and please. Okay. So to start the session, we have got different very expert lectures. Lecturers are there to talk about the topics. So, please.
Right. Good morning, everybody. So we start, though have lesser delegate here, we start a very important session on the arthroscopy. Of course, we do need delegates who are really interested in it, just not for listening, because arthroscopy is a branch where you really need a dedication towards it, to go into it and do it properly. So the session is mixed with a large number of topics which concerns all of us in various fields. To start with, straight away, may I request Dr. Vishnu Das to talk on diagnostic arthroscopy of the knee.
Good afternoon, everybody. I hope you all are having a nice time in Boacon. I would like to thank the organizers for giving the opportunity for this talk, and honorable chairperson and other delegates. My talk is on time. My talk is on diagnostic arthroscopy of the knee. And this is quite a basic talk, mainly aimed at the trainees, not for the stalwarts around here. So for any arthroscopy, either knee or shoulder, what you need is some basic equipment, and the basic thing is a arthroscopy stack where there's a monitor and camera console. You do need a shaver unit unless you are just purely going to look into the knee, but in order to have a proper look, you'll need a shaver. A pump is needed only if you are doing shoulder arthroscopy, very rarely in a knee arthroscopy, and a radio frequency ablator and a printer is a bit of a luxury, I would say, at the moment. What else do we need? We need a trocar sheet, lens, and few equipments. Some really basic equipment is a shaver blade, messenger rod, a probe, and a punch. Now, let's see what we do in diagnostic arthroscopy of the knee. Just keep on going through while showing a small video. So, a diagnostic arthroscopy starts with EUA of the knee. So, you pain break the knee and then do an EUA. So here what I am doing is a pivot shift. So you look whether the ACL is okay. Sorry. Whether the ACL is okay or so you do an UA, look for the ACL, PCL, collaterals, you can do a pivot shift, and then if you are starting, then it's a good idea to mark your patella tendon, make a marking for your portals, and then use the knife, go inside the knee, make it standard, and do your lateral portal first, The standard anterolateral portal is just at the soft spot next to your patella tendon. Then with your trocar and sheath, you go inside the knee, hit the medial wall of the notch and then straighten the knee. As you go in, what you see is the patellofemoral joint. The knee is straight. You'll get a bit of fluid, wash out the joint. You'll see a bit of bonding. And as you are in the knee, what you need to do is rotate the light source, which I will show you. So the basic idea is to keep the camera straight, so you are not disoriented all the time, as I am showing here. So this is the outside view. You keep the light source, and if you want to look at the right or left, you just rotate the light source the other way around. And once you have seen the patellofemoral joint, you dive into your gutters, that is the medial and lateral gutter. So have a look, because this is where you will find the loose bodies. So this is your gutter. You can't see any loose bodies. And then you gently wiggle around, go back into the patellofemoral joint without scuffing the cartilage, and then go into the other gutter. So once you have seen the gutters, I normally do without breaking the table. So this is all with the leg in extension. And once you have seen the gutter, then I hang the leg on the side of the table. And then, because this arthroscopy is done with a 4 mm 30-degree scope, so once you lift the scope at a 30-degree angle, you will be able to visualize the tibial plateau. But before doing that, we need a shaver, because the fat pad comes in the way. Shave off a bit of fat pad, facing the shaver blade towards you, so that you are not taking away anything that you don't want to, that is like the ACL or something very, very important. And then as you tilt your scope to 30 degrees, you can see the medial tibial plateau. Now, in this case, there's a bit of fraying of the cartilage, and then there was a bit of medial meniscus body tear. So I have got another picture where I am focusing on the monitor. This is specifically for the teaching purposes, where the trainees will be more interested in seeing the video from the outside, how to manipulate with the light source and the camera and get a proper view of the inside of the knee. So you can see the angle of the scope here. Then try to visualize the meniscus. Once you have visualized the meniscus, then it is a good idea to make your anterolateral portal, anteromedial portal, and you have to just decide what you are going to do, whether you are going to do an ACL reconstruction or a medial meniscectomy or a lateral meniscectomy or a repair, and that way you will decide whether you want to have a standard portal or a slightly higher or a lower portal. If I am going to do an ACL, it would be slightly higher portal. If I am going to do a medial meniscectomy, it will be slightly, on the middle or slightly lower side. So once you have done that, on the medial side, you go to the lateral side. This is actually the lateral meniscus. You can see the anterior horn and the mid body quite frayed. So let me get this. Just a moment. I'll show this important. So let me just rewind it a bit. So medial side is slightly easier. How to get to the lateral side? So you have two tricks on your sleeve. One, you can just jab the leg on the side of the table and give it a force so that the leg is in varus. But if you really want to see it fully, the body and the posterior horn, then the best way is to get a figure of 4. So here you can see, and the whole trick is not to let your scope come out. So you keep the scope slightly at the 30 degrees, ask your assistant to gently lift the leg up, and with the scope tilted at 30 degrees, you give it a figure of 4. So that way you come in the lateral compartment, and then gently you maneuver with your light source. Make sure your camera is sort of parallel to the floor like this, and then if you manipulate with the light source, you will be able to see the lateral meniscus. And once you have seen the lateral meniscus, you can see the ACL back in 90 degrees. So I think this is pretty much the diagnostic knee arthroscopy. The video goes on a bit more, but if If you have any questions, I'll be happy to take on diagnostic knee arthroscopy.
Thank you, Dr. Hussain. We will take the question in the end.
Sure.
We will finish the lectures first.
Thank you.
So next is Dr. Arvind. We will talk about revision and ACL reconstruction, planning and technique.
So Abhishek, just a question from you, meanwhile. So suppose a case of ACL tear. So do you do a diagnostic first, or you take the graft first, then you enter the nerve?
I always do a diagnostic arthroscopy first before taking the graft. And I have actually switched over to PL graft, so it hardly takes 5 minutes to take it as compared to the hamstring.
Okay. Any reason why you have shifted from hamstring to PL?
Previously, I used to always take hamstring graft, but now I feel that taking hamstring in a knee which is already slightly defunctioned because of ACL, taking the hamstring away slightly more defunctions and prolongs the rehab period. So I have had a discussion with Manit Arora, who is one of the proponents of the PL graft, and sort of switched over thinking that it will accelerate my rehab period. One thing I'll suggest everybody who is taking PL graft is to check the foot first. If they have any foot deformity, especially if they have a pes planus foot, then avoid taking a PL graft.
But still we don't.
I think it should not be the message to the house.
No, I'm not giving you that.
It's just a discussion, it's not a message of hospital तो 10 लोग बैठे ही हैं तो दिक्कत नहीं। नहीं PL ग्राफ आप चूज करते हो। We don't have the long-term data what is going with the foot in the long term after 10 years or 15 years. Do you have any study about the effect of taking PL graft in the ACL over the foot? You have? Because I am also using this. Just I wanted to know from you because you are using frequently.
So I haven't come across any long-term studies because they aren't any. In the short term, what I've seen in a couple of studies is that if they have a pes planus, then it will actually exaggerate the deformity and cause problems.
Okay.
Because one of the literature, what the literatures are saying that the preferred graft is the hamstring graft. So PL graft is kept as a reserve.
Yeah, definitely.
Maybe for revision is.
Apart from rehab, delayed rehab, I mean, any difference like if you choose hamstring or pelvis?
No, the strength.
Why do you give an extra incision when you are going to open that site? It's easy to harvest. I mean, you can easily get a 8-9 size graft. So, I mean, apart from rehab, any advantage?
Rehab में उतना the thing is that the short-term result sets.
That's the point.
Very short-term result sets. So no harm. We cannot say you are doing it wrong. He's doing it very right. The short-term result set. Long-term you have shift from PTB bone graft to ST red was lot of questions and lot of controversies. Nobody was ready to accept it for long years. Nobody was ready to accept it.
Sir, one of the reasons I would say is my initial 2 rugby players of Indian side, they are really very small. So I was slightly afraid of taking the hamstring because I thought it will be really small graft. Whereas PL was really thick, and I actually did PL along with Gracilis in my 2 rugby players, which gave me a decent sized graft. I wasn't confident of taking the BTB graft in that.
So this is actually the persons and the surgeons. They are always in a dilemma whether I am getting a proper graft or not. That's the exactly that they start harvesting the PL graft. But I think so still,
if you get a case of a complete ACL tear with a partial tear of MCL, grade 1 maybe, will you still go for hamstring?
Yes,
Definitely.
Yeah.
But there is a paper that says that hamstring are secondary medial stabilizers, and if we are getting
Obviously, it was thought that a hamstring helps to prevent the MCL, helps to medial stabilizer. But right now there is no thing like that. So if there is any injury of the MCL grade 1, 2,
Even 3.
grade 3,
three complex
yes,
on the medial
both
side, the
together.
postmedial capsule, you have got your semimembranosus and expansions, they are also the medial stabilizers. So still the consensus is to harvest the hamstring grafts, and the other grafts they are kept in a reserve. If you need them, then you can go for it.
एक बात और समझ लो यार कि सीबी टेंडर्स ग्रासलेस ग्राफ्ट का जो टेंसाइल स्ट्रेंथ है, it is very much higher. It has been pushed upon it. मोटा मोटा होना चाहिए because all the European have got a very good. They are just pushing out towards उतना मोटा होना चाहिए. Almost 4 times than the native ACL. The ST and the grassless if you combine together, it's quite strength. Of course, the thickness should be there. It should be less than 6 or 7. We have to get it there. लेकिन 90% of our patients are not really the rugby player as he has got. 90% have just a motorcycle accident, kids coming around having an ACL tear and they will never play hockey, something like that. So we can do either of them. Very good.
There was one thing that switched my thinking. Most of the patients are actually the normal patients.
Indian females, there is some problem of like graft thickness, graft length.
But
in
you
males,
do double or quadruple, Ramadan? You do double or quadruple? The quadruple, semi and grassless is always more than it. It's never less than whatever the thickness of the present. I am telling you, in 90% of the cases, I do only semi quadruple all the time. I take around 1.5 to 2 centimeter of the periosteum. I don't cut the graft. I take all the time periosteum, and all the time size is minimum 6.5. It was never less than that. And quadruple semi help me out in 90% of the cases. If any dot, if it looks like it is less than it, I add it with the grassless. So no problem with quadruple, semi and grassless. If you are making it double, then you will have problem. That I used to do in the initial time.
You can't keep it double design, you have to at least triple it.
No, double semi and double grassless, many a time it may lead to 7, 7.5 or less than 8. But if you do quadruple of these two, you will not have any problem.
What will be the length of quadruple?
Up to 9 plus. You get 9 plus.
Minimum length.
Minimum length, it's 6.5. For me, it's 6.5.
It's all inside or?
It's simple, it's 6.5.
And what do you use like a puncture fixation or an interference screw?
Any of these two.
6.5 and how much in the upper tunnel?
2.5.
For me,
2 is good enough.
In
2 is
TB
good
also
enough.
2?
Yeah, tibia femur 2. This is the minimum. I am talking about the minimum. I am not talking of the
If
standard.
we get 65, it is good enough. Let's
Good enough.
proceed to the next topic. If we get 65, it is good enough. For 65 is the minimum you should try for. Less than 65 again, you can go ahead.
I've seen a recent trend like all those who are new to the arthroscopy, since erroneous harvesting is very easy.
That's why
they are trying to harvest
choice of graft.
just to try to harvest hamstring. This is recent trend.
It's good thickness, it's quite predictable. See, I'm not advocating.
Let's start.
Next topic.
Just having the foot before that.
So this topic is revision ACL reconstruction. As the number of ACL reconstruction is growing, at the same time failure is also growing. So this was the case. This patient came to me 6 months post-op period. Case was done where else. Came to at Paras in my OPD, and patient is himself is doing this pivoting, and at the same time this endodontist. So any abnormal knee function because of the graft failure is called as the ACL failure, and this definition given recently in 2020 only, 22 only by Istanbul. Before that there was no standard definition of ACL failure when you will call ACL is failed. So this was the definition given by Istanbul in 2022. And along with abnormal function, many times if it is associated with the pain and stiffness, then again it is called as ACL failure. So incidence is almost up to 11%, but many literature says it may go up to 25%. So it's as high, depending upon what was the condition of the patient at the time of the, because lot of patient is having high risk for ACL reconstruction. In that case, the incidence is even high. So the causes are the trauma, if you see this reconstructed ACL, this was mine case, you can see it was completely anatomical, but because of trauma it get torn from the midpoint. It was after 9 months of this ACL reconstruction. Technique, another major factor behind the failure of ACL, if graft is too vertical or it's too horizontal also. So in both the case, you may have chances of high risk of ACL failure in comparison to the standard. At the same time, if it is too anterior, then the chances of extension lag will be there, and again chances of failure. If it is too posterior, then the flexion range of motion will be deficit, and again chances of high failure will be there. Another is the biology. If you see this case, the graph looks very strong, but if you see the femoral attachment, hardly there is any femoral attachment in this case. So this is the biology problem. And at the same time, there is missed secondary restraint. Like if you are doing ACL, if patient is having grade 3 pivot shift or very hyperlax patient, recurvatum is more than 10, 15 or 20 degree. So you have to do something on the lateral side also, anterolateral side also. Otherwise the chances of failure will be high. And there is patient factor like less age, 16, 18, less than 20, female, hyperlax patient. All these patients is having high chances of failure of the ACL. And of course the malalignment. This in varus knee, if you are doing ACL reconstruction in varus knee, the varus leads to increased load on the reconstructed ACL and ultimately leads to failure of the ACL. In the evaluation, it should start with the history. Again, you look the patient, age is less than 20, female, hyperlax patient, and high body mass index. All these leads to high chances of failure. And those who wants to resume sports early or very high grade of sports, again, there is all these are high risk patient. So about the timing, many a time it may be early or may be late. If it is early, in 3 month, 4 month time, it's maybe because of your biology, aggressive physio or traumatic one. If it is late failure, like your tunnel is too vertical, so we all have seen that patient came to us after 4 years, 5 years. They says initially I don't have problem, now I have problem. Because vertical graph, anterior posterior stability is very high, but they came late with the pain and instability, all these things, the posterolateral instability part, that is pivoting instability. So physical examination, all these has to be checked, test for all the ligaments, not only for the ACL, posterolateral, posteromedial, very important, and the X-ray bilateral knee, all the time. Look the opposite knee also at the same time. And in the lateral view, always look for the posterior slope, because any slope more than 12 degree in the tibia, the chances of ACL failure is high. And if you are going to reconstruct the failed ACL, then again keep in mind that again chances will be high. So if recommendation nowadays, if it is less more than 12 degree, then try to do the slope correction at the same time. Like this, in this diagram you can see if slope is less in the third one. Pointer है. In the third diagram, if slope is less, you can see here the stress on the ACL is very high because the tibia trying to move posteriorly. Each one है. This tibia try, this if slope is less, try to tibia try to move anteriorly and leads to excessive stress on the reconstructed ACL. So either zero slope or excessive slope will help the reconstructed ACL. And also the long leg film is very important. Stress view, again, if you have failed ACL, stress view is very important. You can see this patient, 24-year male, very bulky guy. You can see the girth of the thigh. Initially the ACL reconstruction along with lateral meniscus root repair was done 4 years back. Patient came again with ACL, PCL and the posterolateral corner injury, 7 months back, and recently visited me 3 months back. This is the posterolateral corner is failing. This is my patient. So again, with the help of stress view only, in case of multi-leg, you can differentiate whether any other ligament is failing or not. So this posterolateral corner and ACL was failing. Very bulky guy. He just accepted the physio rehab. He's done himself as it was done in the ACL cases. So it is towards the multi-leg case. Don't follow the rehab part, and this was failing. Again, so CT, the can I proceed because our two guy is not here, so yeah.
Take another 5 minutes.
Yeah, that's perfect. Thank you, sir. So CT for the tunnel measurement, because with the ACL already you have tunnels, so you can measure the tunnel. At the same time, also the placement of the screws. You can see the 2-time done ACL here. And graph status always with the help of MRI along with the meniscus and this cartilage. And about the cartilage and meniscus, almost 60% will have both chondral and the meniscal nature. So this was the 38-year male, 5-year-old ACL reconstruction. As I said, this vertical graft gives very strong anterior-posterior stability, but the rotatory instability is very less. Patient came, and as this tunnel angle measurement, anything less than 33 is the vertical tunnel. Along in the lateral view, if it is 55 degree within, then it's fine. The long leg film, it was just little bit varus, that was almost equal on the opposite side. So varus was not the factor here, and this was the MRI where the medial meniscus was lost, and definitely ACL is not anymore. And this was the tunnel where you can see the medial meniscus and the ACL failure. And this was the clinical examination. You can see here at the same time there is almost pivoting. You can see the pivoting was also there. That was almost grade 3 pivoting. So in this case, this was the intra-op picture. This was reconstructed ACL, and along with the ACL, because of the grade 3 pivoting, ALL reconstruction was done in this guy. That time I was not doing this modified MRI. Now I have shifted to modified. So this was the ALL reconstruction part. So ALL was done along with the new tunnel was made in the femur as well as in the tibia. And this is after the almost 9 months or 1 year, I think. You can see percentage little bit starting jumping. So with this anterolateral stabilizing with the ALL help lot in case of revision AC. So for the consideration, it has started from the stage, graft, whether implants should be removed or not, tunnel, graft, and rehab. So about the staging, mostly almost 90% of the cases you can done in the single stage only. If tunnel is tunnel diameter is very high, then only you can go to the 2 stage. About the graft, lot of thing has been discussed already. So about the hardware removal, it should be removed only when it comes to your way. Like in that case, the tunnel was not going to hit the previous implant, so that was not removed. And also, if you are removing that screw from the tunnel, like this was after the removal of the tunnel, and if you are using the same tunnel, like in this case, it was almost anatomical. That was the case that I have shown, that traumatic failure was that. And this should be like this after the removing. You should not pass the graft in this tunnel because a lot of soft tissue around the way. So this was the reconstructed revision ACL. In the additional procedure, like this patient having ACL with a little bit of the varus deformity also. So at the same time, high tibial osteotomy with ACL reconstruction was done also in this case. This is the last case. Again, this patient came in 2015 with 2-time ACL reconstructed with posterolateral corner. You can see the screw of posterolateral corner. In spite of here, it is lying there. ACL tunnel is almost vertical. So this was the case. these two screw in the femur with posterolateral corner screw there in spite of fear. So this was the anatomical failure. So in this case, first time I used peroneus longus. This is in the 2015. First time I have used this peroneus longus, and this was quadruple, and this was revision. Third time ACL was done. You can see the tunnel right now there, in spite of there, and the posterolateral corner from there to there. So bilateral hamstring was used because initially all the graft was used in this case. 2-time ACL along with 1 posterolateral corner. So bilateral hamstring was used. And in the previous case, if you see, there was subluxation of the femur over the tibia also because of that failed posterolateral corner. And this is very young child. He was 28-year male, operated thrice at Bangalore. And then he belongs to Patna only. He came Patna in 2015. He got operated. This is the X-ray in 2016. We can see this joint is getting reduced. And also there is increasing space is also there. Everything looks fine. 2016, and this is 2021. Morning time he is jumping. So with properly planning, with properly placed tunnel anatomical, you can have good result even after 3-4 time operated case for ACL or posterolateral corner. In the rehabilitation, always go slow in case of revision. Thank you.
Okay.
Thank you. I will walk to. Go ahead.
Yes, good.
Questions? Okay, so impingement, ACL impingement, also the region of late graft failure, right?
Yeah.
So how do you do it? How do you check it that it's impinging or not during surgery?
So basically, at the time of ACL reconstruction, before passing graft, you just drill with bead pin, and at 90 degree usually you do the drilling with the bead pin. Then you extend your knee and just check your bead pin is going inside the not hitting the femur. That is the first. And then after, if you pass the graft, again you check for full extension. So if it is going inside the notch, not hitting the femur, that it means it's not impinging over the femur.
How much tunnel dilatation you will accept in tibia?
In post-op,
Yes, no, it's a ACL failure case.
12 to 14 millimeter they say you can go with in the first stage. If anything more than that, you have to go in the second
Yes,
stage.
the upper limit is 12 mm.
Yeah.
If it is 12 mm, you can go in single stage, otherwise you need to go for a two-stage reconstruction.
Yeah, true. Because many of us really feel how we feel about getting into 12 or not. For me, I normally prefer a 2-stage. Drilling it past, getting it very clear of all the spinal patterns there in the tunnel. But most of us, ACL are now done by people who are really, they are trained. So the tunnel placing is quite good. And at the same time, you have to go again. You have to have a graph of that side. Either you take both, then it is good. Otherwise, you have to just clear it. You have cleared it. But I don't know how much diameter you have to increase it to get off all those.
So it was non-anatomical. In the both the cases it was non-anatomical.
Then it is fine.
In the another case, the diameter was 10. Even many time I use 11 or 12.
And then getting a.
And a screw, we have facility of 12 screw, both of this arthrex at the same time as Smith-Nephew also. So at my armamentarium, 12 screw is always available.
Like in femur, how much tunnel misplacement you accept? Like if it's anatomical, it's fine, you go through the same tunnel. But in non-anatomical, I mean, it's very important to avoid tunnel position. Right?
So if any dot, you can put a screw in that previous one, and then you go with the newer. And if you think that your tunnel may collide with the previous one, I have done in one case, you can put the screw, block it, and then you go tunnel with the newer tunnel making in the femur. If any is scratching with that, there is no problem. So there will be posterior wall, your graft, and your screw in the femur.
Thank you.
Thank you.
What are your preferred method of fixation in revision cases?
Where femur or tibia?
TBA.
So tibia, many a time I do double fixation. Like in the last case, I did this screw as well as tibial post also. But nowadays I am using this suture disc along with the screw.
Yes, double friction. That is quite. Okay, thank you very much, Arvind. To go ahead with the next, Dr. Gurudev, would you like to talk on PCL avulsion management, please?
Good afternoon, everybody. So, actually, my topic of presentation is arthroscopic PCL avulsion fixation. So, going back when we are a student or as a training fellow, then suppose any PCL cases came during that time, then our mentor said, "You are a lucky guy. You are going to assist one PCL cases. Otherwise, it's very difficult to find out." But believe me, nowadays, in a week, I think we are doing 2 cases of PCL per week. So maybe the number of cases is going to increase because of the road traffic accident or different modality of injury. So coming to the topic. So the PCL is a main static stabilizer of the knee joint. It prevents posterior translation of the tibia and hyperextension of the knee joint. And it acts as a secondary restraint to external rotation of the knee. And it is commonly a part of multi-ligament knee injury due to road traffic accident or during the sports activity. And its incidence varies between 1 to 44% among all knee ligament injury. Isolated PCL injury is very rare. So coming to the diagnosis, the proper history, clinical examination like gravity test, posterior drawer test, and of course the radiological examination like MRI confirm the PCL injury. The partial PCL tear, there is less than 8 mm increased posterior tibial translation. Isolated complete PCL tear, there is 8 to 12 mm of the posterior knee translation. And combined complete PCL along with PLC injury, there is more than 12 mm of the posterior tibial translation. So McIver have classified this PCL avulsion injury into type 1, 2, 3. Type 1 undisplaced, 2 partially displaced, and type 3 is completely displaced. In this literature, discussing about the PCL avulsion, the Mayers reported there is poor outcome with non-operative treatment and suggest that even minimally displaced PCL avulsion should be treated surgically, either open or the arthroscopic method. This is a case of 26-year-old male following road traffic accident. We can see here there is a big chunk of the posterior tibial spine in the back side, and the clinical examination you can appreciate here. There is a laxity of the knee joint, and this is the X-ray and the 3D CT, MRI and the 3D CT scan. You can see there is PCL avulsion injury both in CT and in the MRI, and the rest of the structure like ACL, PCL, cartilage, ACL, cartilage and meniscus are normal. So we plan for the fixation, and there are various fixation methods in the open category, prone position, low and hopper approach or the mini opening incision. You can use the 1S screw, 2S screw, even 3 CCS screw, a screw with washer, 1/3 tubular plate modified, and lastly you can see here the arthroscopic tightrope used for the fixation of that PCL emulsion. This is my own technique. A quick video you can show here how I fix. Usually I do this surgery in a supine position, patient lying supine on the operating table, and the leg hanging on the side of the table, which mark all the bony prominence. I used 3 portal technique, 2 anterior and antero lateral and anteromedial standard, and another one posteromedial portal. So after introducing the scope, do the proper lavage of the knee joint, and you can see it here. There is slopey ACL in the knee, and create the first space between ACL and the PCL by removing the fat pad and the synovium, so that you can introduce the scope in the posterior part of the knee joint. Then create the posteromedial portal with the help of the spinal needle and the 11 number knife. Be sure your knife is tied with the thread, so that you cannot miss. Then introduce 8 mm plastic cannula. Then use the saver to create the space in the posterior aspect of the knee joint, to remove the synovium, fat pad, bony debris, and clean the gutter of the PCL emulsion, and make sure the avulsed part of the PCL is freely mobile. With the help of probe, you can try to reduce it in the gutter. Little bit there is combination of the fragment in this case, and this avulsed piece is easily reducible with the help of probe. Then I use the lasso. Nowadays we are using the scorpion also. So pass the thread at the junction of avulsed piece and the ligament, loaded with fiber tape. Then repeat the procedure another second time to encircle all the dominant movement. So the encircle all around the ligament and bone junction with another suture material. With the PCL jig, it should be at 15 mm below the joint line, and pass the guide wire from the anteromedial on the side, and the big pin coming just in the base of the gutter, and drill over the guide wire with 4 mm of the drill bit. Then pass the big pin in the reverse manner, loaded with the loop thread, then hold it from the anteriorly, then load it all the thread through this loop wire. With the help of the probe, we are trying to reduce this avulsed piece into the gutter, and gradually we have absolutely reduced that fracture fragment, and this is the final picture. The PCL totally tight, and there is absence of slopey sign of the PCL. And anteriorly we tied this thread over that suture disc, and this is the intra-op picture showing the knees looking quite stable. And this is the post-op picture, in CR picture inside the theater. We confirm whether we have reduced that fragment or not. post of X-ray, and this is the post of picture after 1.5 years. Thank you.
Right, any questions?
So, where do you make the tunnel in the posterior part of the tibia? It's in the crater or below the crater?
No, in the crater, just touching the crater.
So, in that case, it was inside the crater. That's
Inside the crater, and it is just inferior margin of the our head. We are just coming inferior aspect of that.
If you see the video, it's in the crater. So,
You in the crater, I am taking in the crater.
below the crater, so that you completely get covered. It should footprint should be get covered with your eval body. Also, at the time of making interval between the ACL and PCL,
Yes.
start your saber as high as possible. If you keep your saber low, then the chances of converting the PCL fiber will be high risk.
I think
Like in this case, you should, if you start as in the notch as high as possible, then the damage of the fiber will be less. Like in this video, there was converting the PCL tendon also.
Before beginning to use that saver, I use the radio frequency. Just
Yes, perfect. So radio frequency is more
get
controlled.
some excess and then use the saver.
Start high as high as possible.
From the notch.
So this will prevent the damage of either ACL or PCL tendon.
Boss, you can also skip that portal if you make another middle entry or a lateral portal. Or you can just skip that.
Without
You
removing.
can make two medial portals and then do all everything.
No, without going from inside. How can
You can make the medial portal.
No, that was another thing. The medial side, one working portal and one viewing portal.
Right.
Sometimes we are using one medial portal and another lateral portal also, posterior lateral portal also. But without creating this space and not going to see posterior aspect of the knee and prominent.
Modified Gilchrist you can do between the PCL and the medial condyle. You can just pass it and
Anyways, actually you have to push the jig. You have to place the jig. If it is the jig, you have to go there. Even if you don't want to go, you can place jig your from the posterior medial portal only. You don't have to go anything anteriorly. There is a technique, you can pass your jig from the posterior medial portal and the bullet of the jig will hit over the anterior part of the tibia. You are not visiting tibia anteriorly knee anymore. If you making the two portal there and one portal from the posterolateral side.
You
But
can also make a superior, posterior medial and an inferior. You don't want to go.
But if you are making single one, then anyway you have to go in between ACL and PCL for passing your jig.
but for making the medial portal you don't need to always go between the cruciates. You can
No. Another thing, you can go through the medial condyle and the PCL also. Okay, but in my hand we are little bit more comfortable between ACL and the PCL.
When you are doing an ACL surgery, you go and check for ramp all the time. So you make a portal to see the.
No, right now in our standard practice we are not going to create another more portal to check the ramp region. We just check from the front. Yes. While doing
You
the
can
ACL
see all the
surgery.
things from the
Should proceed for you. Yeah. Basically, thank you very much for that. Very nice talk.
Next is Dr. Manish. We will talk about epidemiology of ramp lesion.
Okay, once again, greetings from behalf of the Boacon. So today we are going to discuss upon a topic which is commonly missed while doing the ACL reconstruction, and that thing is called a ramp lesion. Okay. So regarding the ramp lesion, the word ramp lesion was first described by Strobel in 1988. And according to Liu and others, it was considered to be a longitudinal tear in the peripheral attachment of the posterior horn of medial meniscus with a dimension less than 2.5 centimeters. And whenever you talk of a ACL lesion or tear, the most common intra-articular pathology, associated pathology, is the something wrong with the posterior horn of medial meniscus. And the incidence of ramp lesion varies anywhere from 9 to 34% in association with ACL tears. Conditions where isolated ramp lesions has been described, and that is seen when there is a longitudinal split in the ACL or in degenerations. Over the last few years, there has been an increased attention towards this ramp lesion. Now, when I talk of ramp lesion, why the word ramp has been described? It is basically due to the type of tear pattern. It basically is the anterior aspect of the tear is slightly placed superiorly than the posterior aspect. And the first classification of a ramp lesion was described by Thornett and others in 2016. And why this ramp lesion is usually missed? It is basically because when the knee is in extended position, the posterior capsule is pulled backwards and it obliterates the posteromedial recess. And similarly is the condition when the patient undergoes an MRI examination. And the MRI is usually performed in an extended position of the knee, and this also leads to the obliteration of the posteromedial recess, which obliterates the ramp lesion, and even if it is present, it is not visible. So this is the classification given by Thornett others, and you can see the classification type 1 and 2 are considered to be stable 1, and 3, 4 and 5 are the unstable ones. So what does the stable lesion mean? Here the capsular ligamentous complex, it is adherent firmly to the posterior horn of medial meniscus and it does not move with the extension and flexion of the knee joint. So theoretically these lesions are considered to be stable lesions and they can heal by a non-operative treatment. Whereas the unstable lesions are those lesions where the capsular ligamentous complex is not attached firmly to the posterior horn of medial meniscus and there is a gap or dehiscence. This is a pictorial diagram where you can see this is the ramp lesion. This one, marked by red color. Here again the diagram is shown. Now basically what does this ramp lesion, what is the problem with the ramp lesion? See, in ACL deficient knees, there is the posterior horn of medial meniscus acts as a secondary stabilizer and it also secondary stabilizer and it prevents the anterior tibial translation as well as the posteromedial rotation. In patients who are having a ramp lesion, associated ramp lesion, you go for ACL reconstruction and you do not look for the ramp lesion. So over a period of around 2 years only, there is an accelerated degeneration of the cartilage of the middle compartment. So if the ramp lesion is not addressed, it leads to a persistence of instability, and in order to identify the ramp lesion, you should have a high index of suspicion. So in order to have a high index of suspicion, you should also know what are the risk factors which you should look for to identify the ramp lesion. So there are some risk factors. Studies have shown that the age, sex and the injury mechanism does not have a direct correlation with the presence or absence of a ramp lesion. But some of the studies says that persons who are less than 30 years of age has got 1.6 times higher incidence of getting a ramp lesion, whereas male patients similarly 1.5 times higher risk of getting a ramp lesion. But there is no statistical correlation between the presence of a ramp lesion and the degree of anterior draw, lateral or pivot shift test. Similarly, a very strong correlation has been seen with the ramp lesion and superficial and deep MCL tear. Similarly, if there is a presence of bone marrow edema in the posteromedial aspect of the tibia, one should always try to look for a ramp lesion because that is also a risk factor. And when I talk of a slope, the posterior tibial slope, if you have got a steep posterior tibial slope on the lateral side, that decreases the incidence of ramp lesion, whereas the same if the slope is less on the posterolateral tibia, there is a high risk of ramp lesion. Also, if the patient has got a side-to-side discrepancy in the anterior tibial translation more than 6 mm, then you should always look for a ramp lesion. Contact injuries and non-contact injuries, they have not much correlation. So a lateral meniscus tear, if it's there, they will also try to look for a ramp lesion. So in order to identify a ramp lesion in a patient of ACL tear, one should go in a stepwise manner to identify it, and that is a systematic stepwise arthroscopic assessment. This can be one of the positions by which you can perform any arthroscopy. Others can do whatever method they are comfortable with. Now here I will show you one. A window needs to be created. Video I think is not playing. Okay, and that to show there. Also try to create a window between the PCL and the medial contact of the femur and the medial tibial spine. That can be your entry point, and from there you can negotiate through this point into the posteromedial compartment. So once you have entered into the posteromedial compartment, as you can see here, you have entered into the posteromedial compartment, then with the needle from the posteromedial aspect of the skin, you should try to negotiate the spinal needle and look for the trajectory of the needle to place the posteromedial portal. So see, there is the needle which has gone inside, so that gives you an assessment. And let me try to show you a ramp lesion. How does it look like? सब आपकी वीडियो प्ले नहीं होते हैं. Okay. So after having good signs of your high index of suspicion and looking for the risk factors, see, you can see by anterior probing, you're pulling on the posterior horn of middle meniscus and you probe easily negotiating under the posterior horn of middle meniscus. And once you pull it forwards, you can see there's a wide gap between the capsule and the posterior horn of middle meniscus. So this is quite suggestive that the patient is having a ramp lesion. And of course, it is not grade 1 or 2. It is at least 3 or 4 because it is coming inside the joint. So once you are having an assessment regarding the risk factors and having a high index of suspicion, you should always look for a ramp lesion, because if you just go for a ACL reconstruction without looking for a ramp lesion, then you are always going to land up with a condition that is called a persistence of instability. So the take home message will be, whenever you are dealing with the ACL tear, always try to look for a ramp lesion because there is a high index of suspicion and that can help you out with that. Thank you.
Thank you very much. Very nicely presented. Can I now request
May I ask one question?
very small question, a very small answer, please.
Yeah, Manish was,
Yeah.
in the video, you said it's very, the posterior horn of medial meniscus is coming anteriorly, but there is no any gap in between the capsule and meniscus.
There was a gap. It was not very gap because
the membrane
I
is
was
continuously.
yes, it was membrane continuum. Yes, it was
If there was any gap.
Probe was not going through.
Yeah, not going.
And the last part you saw, the probe, it was not coming out fully, but the amount of when the meniscus was pulled forwards, there was a good amount of translation of the posterior. So that was suggestive that there is some evidence.
So message should be, if there is a gap,
Yes,
then only it should call as a
ramp lesion.
Now, will you repair that?
Will you repair that?
I do not repair the only diagnostic one. Yes.
I think the things happen. So
But it does not break.
let's go further. Fast moving, and may I call Dr. Raja Anurag Boacon for his talk on rehabilitation after the ACL reconstruction. Very important topic which we all need to know.
Good afternoon, everybody. My topic is for rehabilitation following ACL reconstruction. This is for the beginners who have just started, not for the next level stalwarts who are sitting here. Okay. Choosing this topic because ACL reconstruction is one of the most commonly performed arthroscopic procedure nowadays. And incidence is pretty much all over the world. In USA alone, it is about 1 lakh per annum. Another ACL is the primary anterior stabilizer, secondarily the restraint to the tibial rotation. So the purpose of ACL reconstruction is maximizing the knee stability. Rehabilitation protocol, what we are discussing here, is based on the time based, also based on the criteria which person have to pass through to go in the next phase of rehabilitation. And in some cases, specialized condition, we have to go a specific intervention also. Time frame is also not strict. It is likely to vary depending upon surgeon's preference, patient's condition, and the complication, whatever is there. Another thing also, the associated injuries also like hamper the time frame or change the time frame. And rehabilitation will be taken in the following heading: goal and intervention criteria to progress to the next level, a specific consideration for the specific sports and a specific demand of the patient. And rehabilitation starts not only after the ACL reconstruction, it starts pre-operatively also. And goal of rehabilitation before surgery is symptomatic relief, mainly pain-related, pain, swelling, restore the range of motion so that we can go for arthroscopic procedure as much as muscle strength, whatever it can be, and last but not the least, psychological preparedness for the surgery. Now coming to the post-operative. Again, the goal is to protecting the graft tissue first. Now the symptomatic control of pain and swelling, following the mobility, patellar mobility most important is there. And for passing first phase, person must have got full extension as compared to the another. And gradual improvement should be there in the flexion. Another, the muscle inhibition, arthrogenic muscle inhibition should be minimized, and patient education is also quite important. Intervention for the swelling management is the cryotherapy, retrograde massage. For the range of motion, patellar mobilization in all directions. Assisted knee mobilization should be there, and in the beginning, it should be low intensity and long duration extension stretches. In the latter stage, it can be high intensity, short duration. So it can be achieved with the prone hang, heel prop, and for clustering the soleus stretch also quite is helpful. And supine active and passive hamstring stretch is also quite active. In these pictures, it is quite significant how it is being done. Now, strengthening of quadriceps and SLR should be there, but for SLR, there must not be any extensor lag. If any extensor lag is there, it must not be done in the phase 1. Again, a special consideration is the query from the patient side regarding walking, how patient should walk. Initially, it should be brace lock with the crutches. Brace locking should be done once the patient is able to do SLR without any lag. And discontinuation of brace after 6 weeks only after the quadriceps adequate strength is there, and crutch can be discontinued after the symptomatic relief is there from the pain and swelling. Again, another is regarding the climbing stairs. While going up, patients should go with the non-surgical side, and going down, patients should go with the crutch and surgical side. So, in any condition, in the climbing or going up or down in the stair, the operated legs would be always above, and non-surgical legs would be down in the both conditions. Now, for going into the second phase, there should be full extension of knee, and quadriceps contraction should show the patellar glide. And another thing, patients must have straight legs without any lag. Now, coming to the next phase, phase 2, early post-op phase. In this again, we will proceed with the graft protection followed by full range of motion, normalizing the gait pattern. Range of motion exercise should be there with the stretching of all the group of muscles, and a strengthening of all muscles, especially the hamstring also is there. It's quite important for taking this. Squat should be there, but it can be done all mini squats, especially walls and mini squats. Pelvic strengthening should be there also. The picture we are showing in such a way we proceed. In phase 2, we should encourage the balancing and progressive perception also, especially over the single leg standing balance should be there. Can be lateral step over, joint position sensitive. Should be also promoted by training. And for going in the next stage, there should be no swelling. Flexion gap can be 10 degrees as compared to the other side, but there must not be any extensor lag as compared to other. Quadriceps strength will be 60% greater than the uninvolved side. And whole is the graph after coming the third page, again we will proceed to the same way. Graph rotates on, and now we have to achieve the full range of motion, strengthening all the muscle, and gait patterns should be normalized. Here again we have to avoid pain and swelling while doing for exercise. Another any activity which causes pain at graph femoral side must be avoided. Intervention will be additional in additional to previous page 1 and 2. Again, the range of motion strengthening will be promoted. And where hamstring autograft have been taken, there resisted hamstring strengthening must not be done till 12th week. Phase 3 leg again intervention continued in such a way, single leg progression. Again, the partial weight training to single leg press test. Slide board lunge, retro and lateral, seated leg extension. Seated leg extensions can be done here, but any leg balance over the peak board and balance board could be used. Treadmill only flat, no mountain hill or climbing over slope should be allowed in this stage. Again, for going to the next stage 4, again we have quadriceps strength here.
Just take a minute, please.
Quadriceps strength should be 80% here, and gait should be normalized, and full ROM should be there. And infusion should be minimal hotness, and again the position should be with a margin less than 5 degrees. Now is the fourth phase. Again, quadriceps strength should be increased, and we will introduce jogging, light running, agility training, and hop test can be started by the 12th week. After performing hop test, we can be transitioned to the fitness facilities. Intervention again, the sub-max sport specific, not the maximum, but the sub-max sport specific training can be started. And bilateral partial weight bearing polymetrics to full weight bearing polymetrics can be initiated. For hamstring graft, again here we can start at the completion of 12 weeks. Resisted training for the hamstring. This is the hop test what we need to do before starting the sports training.
Requesting Doctor, please conclude.
After 12 weeks, we can start the hop test at functional activity. We can start, and PS sports will be there either 12 by up to the 5th month, or after 6 to 9 months we can start the completing the sports activity. We need to wait, that will be better for us.
Thank you very much. This is a very nice presentation. Very important aspect, more important than the surgery of the ACL itself, proper rehabilitation. Thank you, doctor.
Next talk is by Samantha sir. We will talk about arthroscopic repair. Arthroscopic level repair, cup repair. Sir.
So I am in the arthroscopy session where I am going to talk on the rotator cuff injury, because every day when we do see some calf injuries, we clinically test those cuffs whether he has got the supra, intra, or the teres, or the subscap, or the biceps. All the 5 things are important, okay? And also the range of motion, they are also compromised range. Then we see the MRI what is the extent. Then we see what is the atrophy, we classify them according to the Cotellier classification. And what is the age is always important. There is a lot of controversy about what you do with the biceps. Whether the biceps will be cut, it can be tenorized, whether intra-articularly or the suprapectoral or the subpectoral. But now the technique is when I think most of the people, those who are my friends here, who are doing arthroscopy regularly, sometimes we see that the calf is not in a single layer, it's a double layer tear, it's a laminated tear. So what to do with the laminated tear? I am going to present something which is specifically for the laminated tear. Because if you see this picture, and if I stop here, you see there are 2 layers on the supraspinous level. So even if you take a bite of your scorpion, probably you will be taking bite at 2 levels of the supra, and one bite will be proper for one layer, but it will be a completely fragile bite for the other layer. So how to go ahead with the delaminated tear in the supra or the infra? So first, whenever you go inside, you have to decide whether the biceps has the got the right to stay inside the joint. If you are happy that the thing is that the most notorious part of the biceps is the groove, because that part of the biceps has got the maximum nerve supply. So if you do something and if you don't check that what is the condition of the biceps in the groove, and you just terrorize intra-articular the biceps, that guy will never be happy. So please check that. You try to pull the biceps from the groove and try to see that there is no not we talk about this is a lipstick synovitis. When you see that sort of synovitis in the biceps, please don't do the biceps tenodesis suprapectoral or the intra-articular. You just cut it off, patient will be happy. Or tell them that you might get a papaya sign. Or else you do these subpectoral tenodesis in the guy here. Now you see I have checked this biceps is okay. So I am doing with the one anchor which is strictly loaded. I am just doing the suprapectoral or the intra-articular biceps tenodesis with the technique of the lasso loop, which has been described by the great person Laura Lapos. Okay. So this is the technique how you take the lasso loops. Even you can take this sort of lasso loops for your cup repairs also. So I have tenodized the biceps. I have used the anchor for the bicep. I have taken 2 bites in the biceps. So I have already tenodized that part of the biceps. Now, once the biceps has been fixed, you take the rest part, the intra-articular part that you take off. Okay. So now the question, how you repair the delaminated tear of the supraspinous. This is the now you see if I stop here, then I think everybody will before we go to repair the cuff, you have to check the reducibility. Never just drag the cuff to your reversal. If you do that, basically it is a day 1 failure. You can, how much people ask how much you can medialize your footprint. Maximum you can go up to 10 millimeter. So 10 millimeter, even if you take off the cartilage, you prepare the footprint. Now you see this cuff is not very good quality. You see there is lamination, and also it is more or less from the top. If you see from the posterolateral corner side, you can see the glenoid. Now I am releasing at the 12 o'clock, so that unless you release at the 12 o'clock side, then the cuff is not going to reduce. And remember that maximum within the 12 o'clock you can go up to 1.5 centimeter. Because if you go beyond that, then probably you are going to hit the suprascapular nerve. So now we have released that. Again with the magic grasper, you are checking that how much is the reducibility. Then you check that it is coming properly. Now you see that there are 2 layers of the supra and infra. So what is the technique? Some people you can take the margin converters. You can just make the big tear of that U-type sort of tear. You can convert that. And now with the scorpion, you see with this you can take with the bites, with your butt beaks, with your relay suture or your scorpion. But remember, whenever you take the bite, always take the bite in such a fashion that you always take the deep layer. Because if you just take the superficial layer, then it is a day one failure. This is 100%. This is going to re-tear because the deeper layer is the thickest layer. The superficial layer is the much thinner layer. So you have to take the bites properly so that you check that you have taken the care of both the layers. So I think those who are doing, they are all expert, Gurdev, then Arvind, then the other people, we all have learned very hard how to tackle the sutures inside during because there are 8-12 sutures inside and you won't be able to tie any suture unless you have taken all the bites. So suture management is always a problem. So now you see that I am using the same way of relaying the suture because this I learned from one of the masters because he uses only this technique because in this scorpion if you take a bite you won't be able to take the bite in different places. Even you see that I have taken the bites one by one. The reducibility, reverse L or the L will dictate you how you take your bites. Then you can come from front to back or back to front and tie the sutures from in the reverse order. So this is the way how you take your bites. And you see now I am going bit medial. Now people say you don't take too much of basa from the dorsal side because that gives in the facility of your relief. Now you see I am taking the bite from the back side. I am taking the bite so that I am taking care of the deep layer. You see, I am going such a way that I am taking the deep layer first. Even you can repeat the bite of the superficial layer. Once you have taken all the bites and you have seen that you have taken all the take care of the deeper most layer, then you go on tying your sutures. I never use any other knots other than the alternate half pitches in any of my shoulder surgery or any surgery. And remember that the junior people that don't tie very hard on the calf tissue. You don't tie very hard like your bad cutting, push your knot push are very hard because you just have to give only 6 alternate half pitches and you will be happy. You see, ultimately when you put all this deep layer inside, then only the whole calf will be sitting on the foot. So I am not going to detail all the very intricate issues how you repair your calf. I just want to put one point that always remember when you see the deep delaminated calf tears, take care of the deep layer because unless you take the deep layer with your suture technique, then probably it's a day one. Thank you very much for your time and patience.
Thank you, sir.
Questions?
Do you always do a double row repair for your?
No, I never do double row repair most of the time because I don't believe that the double row is at all required. If you see the literature, the re-tear rate with a single layer, the double layer is more or less same after 5-10 years.
The speakers and the chairpersons please gather the podium outside for the collection of memento and presentation. So thank you, sir, for very nice talk and very nice demonstration.
Thank you.
रिकॉर्ड हो गया
Thank you.
बंद कर देना सर।
अरे क्या खबर यही जस्ट
Very good afternoon to all of you. We will be starting our arthroplasty session in a time. The chairpersons will be Dr. John Mukhopadhyay sir, Dr. Raja Anurag Gautam sir, Dr. Manish sir, and the panelists will be Dr. Rajiv Sinha sir, Dr. Vidyasagar sir, Dr. Ramit Gunjan sir, Dr. Wasim Ahmed sir, and Dr. Nasir Ali sir. I request everyone to be seated and let's start the session. And I'll request my our speakers to kindly adhere to the time. We are running slightly short on schedule, so please.
Hello. Yeah, so I think we should get started. The first talk is by Dr. Sudeep Kumar, who's going to talk about acetabular defects, the management principles. So over to you, Sudeep.
Good afternoon, everyone. Thank you. So, managing acetabular deficiency in CHA, it's not an uncommon problem nowadays with so many monopolar or bipolar arthroplasty being done at an early age and with patients coming with pain later on. Then there are plenty of acetabular young patient trauma happening all around our part of the world. So it's not a uncommon scenario with patients lining up with you with arthritis, arthrosis of the hip joint and having defect in the acetabulum. So let's see a little bit theoretical aspect and what we do in our patients when we land up in such situations. So there could be many reasons of bone loss. So post surgery could be due to polyethylene wear induced osteolysis. But we don't see this particular thing more often than what we see is that when we take out an implant, a loose implant or an infected implant or already there is a monopolar or bipolar hemiarthroplasty or a post-traumatic acetabulum as I mentioned. So many classifications are there. Pathology classification is there 1, 2 and 3, 2A, 2B, 2C. I'm not going into the deeper detail of the classification, but then what I'm going to tell you and give you is that you need to know where is there a superior migration of hip sentence. Okay, and the reference of this will be superior acetabular line. So if as compared to the other side, because there will be a time when the other hip would be that this hip is already operated. So you have to compare it with the other hip, whether operated or not, and if it is normal, you can find out whether the hip is superiorly migrated to the obturated line. And then this will detonate or tell you that there is a superior acetabular dome loss. Okay, that's one. If there is an osteolysis of the teardrop medially, then it means that there is an inferomedial and medial wall bone loss. So that is very important, that what is the deficiency, what is the problem, you will find out what you are going to have. Ischial osteolysis, that denotes a posterior inferior column is gone. Okay, you need to know what is gone before you actually go inside. And if it is polar line or iliosteal line classically,
then anterior superior column and the medial wall is not. So just keep these 4 things into your mind, and so these are the things, 1 in the picture, 1, 2, 3 and 4, and you will have a basic idea without any much ado that what is going to happen in this patient. So this is a typical scenario with the failed, the hip has gone up and it is migrated. So you know what is going to happen when you go in. Now, second most important thing is that it rests upon your cup, whatever you are going to do is rest upon column, 2 columns. So anterior superior and posterior inferior are the 2 strong buttresses that you have for your cup to hold. And these are the areas where you get your screws in place as well. These are the areas where you are using a cup cage construct, your cage fins are going to go. So these are the 2 important areas that you need to aim upon before you jump on doing any kind of revision, acetabular revisions. Okay. Now, type 1 is an undistorted hemispherical acetabulum. There is bone loss, but you can manage with weaving and give a big cup. Type 2 is distorted, but the columns are more or less intact. That's the nutshell. Okay. I told you the Peperowski 2A, 2B, 2C, 3A, 3B, C3, but in nutshell it is 2 is distorted acetabulum, but intact columns. Type 3 is distorted and non-supported columns. So 3A is up and out, 3B is up and in. Okay, so these are the basic and very basic for the acetabular defects to understand. Okay, so 2A is basically rib defect, bone loss is in the superior lobe, anterior and posterior columns are intact, and most of the bone, host bone is there. Okay, so you just take out, and if the cup is loose, lucky, you take out the cup and then you remix with a porous uncemented bigger size cup, and you are good for the day, like in this case. But you have to remember that there are times when these screws are not coming up, so you have to be ready to take these screws out with a burr and all, because you may just pull, and if you are pulling it too much pain and all, this is just 2 screws, but there could be 3 or 4 screws people have put in. That will lead to a lot of bone loss, which you don't want actually, because it's a very simple and easy scenario to manage. Don't damage it based upon your own haste and judgment that you're going to do in a hurry. Okay. 2B, less than 1/3 of the dome is disrupted, and around 70% of the residual host bone contact is there. Not more than 70, but around 70% of the contact is there. And as said, type 2 columns are supported. Okay. So not bigger, so you can use a multi-hole, highly porous cup here. Multi-hole, why? Because you don't know which areas you're going to fill in. Which areas will take your screws, because you need support, because around 65 to 70% of only residual bone contact is there. You want to give a better bone contact, you can use allograft, because if these is a scenario where the surgery has already been done, you don't have a femoral head to deal with. So that is another issue. So you cannot construct the defect area with the femoral head. So you need to have an allograft, or you need to have an augment. Okay, so these are the 2 options, but you can very well do away, easy to do away with these cases as well. Okay, type 2C theoretically is a medial bone loss. You can use a jumbo cup, medial ward bone graft. You can use mesh and bone graft, and you can use adjuvant screws. Okay, so this is one of the examples where the cup has gone up. You will have a medial defect. You can use this type of construct, but use a bigger cup so that your columns hold them. 3A up and out. So this is more than 3 centimeter of migration, and collar line is intact. So hemispherical cup is partially supported, and here the options are ready. Okay, you can use cage cup cage construct, structural allograft with the access we don't have. Impaction bone grafting, a jumbo cup, a tri-flange cup, or except a high bone center. High hip center, if a small cup was used, use a high hip center, put it in a native acetabulum. If you have a small, put a small cup. Okay, these are some of the examples, fail and cup cage concept. But remember that there is a high failure rate of these stages. It's not a panacea. You give a very good post-op X-ray, but these have a high failure rates. These are not easy to manage in the post-ops. The high failure rate of these. These are not biological, not integrating. So fatigue failure of screw and flanges are very, very common. So this has to be kept in mind when you are counseling the patient. Okay. So result of allograft is also valid, though we don't have allograft, but it's also very valid. These are some of the stuffs from our armamentarium. So we use cones, So we have used, so in this, like this, you have to use a cup cage construct. You can fit the cage in the IVM or in the IVM anesthesia, and then you cement it. Okay. So these are some of the scenarios. Chronic pelvic discontinuity, you can use a bigger cup. Just skip through all these and just do last few slides. So these are some of the cases where you can use augment, build up the superior wall. These are long term. I think this patient we have used bone graft. So they osteolize over a period of time, but they can again solidify. So proper assessment is very important. You need to prepare an inventory prior to the surgery. Have a team meeting before your team, before the implant guys and all what is they are bringing, and then go ahead to do these cases and discuss with the patient what is going to be the outcome, long-term scenario for these patients. Thank you.
Thanks, Sudhir. Next speaker is going to be Dr. Ashish Singh, sorry, and who's going to talk about the cup cage concept in managing acetabular bone loss.
Very good afternoon to one and all. I'm very thankful to the team for inviting the faculty in Rajgir. It's been wonderful here. And I will be talking on cup cage construct. And Dr. Sudeep sir has very nicely elaborated what are the pros, cons, and diagnostics classification. That on which my talk will be also based. Slide show, please. So cup cage construct in acetabular bone defects. It can be used in neglected acetabular fractures. I have my papers on it. Revision total arthroplasties and of course in acute acetabular fractures. These are some indications. So these are the typical X-rays which we get in our scenario in India, and patients are either non-treated or neglected. There are some papers which show about the acute acetabular fractures where we have been using cup cage construct, and especially by Dr. Rajesh Malhotra sir, New Delhi. And this is my paper where I have shown to use cup cage construct in neglected acetabular fractures. But the goal remained the same: stability, restoration of the COR, and a correct understanding of the bone defect. So, my aim during this presentation would be to make us understand when to do a cup cage construct, algorithm, complications, how do I do it, and of course a take-home message. So basically, classification is a mandate, because if we know the classification, then we can analyze what can be taken care of. I basically take care of 4 lines: cold line, acetabular drop line, tail drop, and ischial lysis, vertical migration. Very minutely look into our cases, analyze, if required we do a CT scan, which I will show it to you, and we have array of options available. For the purpose of this talk, I will be focusing on cup cage reconstruction system. Before we start or embark on any procedures, we need to understand why it has failed. If I ask you what is X-ray, it's an absolutely perfect X-ray, but we need to look into it and understand why it has failed. And planning is very important. We need to plan. We can have digital orthogonal templates if you have it. Otherwise, you need to make sure that you have 3D plan. I think AIMS has got 3D printing availability options, so we can get things from there. And these are good concepts. You can have 3D models. And if there is more than 1 centimeter interpelvic migration, it is good to have a angiogram. So prepare yourself and the patient, as rightly said by Dr. We need to plan ourselves and the patient for failures. And we should know the understanding, we should have an understanding of the classification systems. I won't go into the detail, but basically there are 3 classification systems. The American Academy of Orthopedic Surgeons, they classify intraoperatively, so it's of no use, and we have to see and again classify it. Paprosky system and the Gross systems. And these are some basic things which has been just elaborated very nicely by Dr. Sudeep sir. So Paprosky's classification we need to understand and which type we have to go. I am very proud that I have worked for Mr. Popresky in a couple of cases in America. So these are things which has been elaborated, and I won't focus on this. But I will be focusing on things like gauges. So this is the algorithm which we should understand. That in 3B or 3B acute discontinuity, we can use either an augmented system with proper planning or a cup cage construct. And a cup cage construct is not easy to do, because you need to have a 3D exposure. It has got a high complication rates. But we need to first of all expose the acetabular in a very good way. use the approach which you know and do it well. Don't think that for the revision there is the posterior approach and everything you do anterolateral or for that matter direct anteriors. So first you need to expose the acetabulum and remit, see the defect, then implant the revision shell. This is highly a new concept. So you implant the revision shell, then you mold the cage. Cage molding is essential, I'll show you some cases. And mold, and then you have to screw it, then put your cement and then take it from there. So if you have to very meticulous, you should have models and you have a sample, you can mold it on the table and take it from there. So then putting it and then you can go for cemented options. So coming to the literature review, the complication rates are very, very high. And aseptic loosening, of course, infection, aseptic loosening, nerve injuries are very high. And implant revision rates are also high because a lot of dislocations happen because we don't plan the horizontal offset in these cases. So sometimes we can bail out of all these without using things. We can use augments. So we should have an understanding of the augments which we can use. And these are some augments which we have used very rightly and take it from there. Sometimes people use bone graft, not my picture, but this is sometimes what they do. Sometimes they cut the cup, which cannot be done, but this has been done at my previous center in England, where we used to cup the cake. Cup actually, and it was a Mathis system, which is uncemented plastic actually. So need for internal fixation, this is what I prefer, and we generally, this is a half molded cage. So this is a good option, but on the cup cage construct, it is very important to have your ischial marking and put the cage at the right place. And in some cases, we have put the cage along with the mesh and take bailed out from the situation. So these are some of my pictures, but these are pretty complex cases when infection rates and all has to be explained and long time of surgery, approximately 600 ml of blood loss. We need to keep in mind about the options of instability. We need to choose the cup accordingly, restore mechanics, red size and constraint. So somehow we do have constraint liners at Patna at least, so we can use it in some scenarios. So this is just a revision of the same cup. We have used a constraint liner, not my case, but this is an option. So we have very well, this is one of the papers by Dr. Rajesh Malhotra sir, showing cup cage constructed acute acetabular fractures. And for knowledge, I am showing this is a cone cup, which we used to use sometimes in the UK, very rarely, especially in tumor patients. So the aim should be safe, durable, advantage of what it is already, avoid unnecessary trouble, keep it simple but be effective. Some cases which we get pelvic discontinuity. In my opinion, I try to preserve all my bone and use the head and take it from there. So this is another case where we have peripheral locking cups in the cup. So you can't see it, but if you can zoom it very well, you can see peripheral locking system in the periphery of the cup. So with the two screws as well, we have multiple 4 to 5 screws which can be fit at the periphery. Sometimes we get like this, we can use Murphy's hat. Understand the anatomy. Sometimes we plate the acetabulum and do the reconstruction, something like this. Or sometimes when nothing can be done, this is an acute acetabular fracture where percutaneous fixation of the anterior column and the posterior column was fixed with plate. So these are some examples of acute fixation, but we have not gone into cup case construct. So this is a small video with which I will end. So basically it is of paramount importance to know your acetabular anatomy and the pelvis anatomy. Make sure you bend the flanges in a good way, and once you bend your flanges, it's the last slide actually. If you bend your flanges, it will actually fill up. If you don't do this, you will end up in cup which is not fitting up very well in the ischium and the rami. So you need to have a good exposure. As I told you, fit the flanges very well, accordingly screw it, and then at this point you can screw it and put cement and take it from there. So nothing more. Conclusions. I try to preserve my bone and use some fixation and take it from there. And cup case construct is the last bailout options. You should be very cautious. Some cases in which cup case construct has been used and it has not been successfully done. So we need to discuss these things, that these are the problems which we need to analyze. Before embarking on these procedures, we should understand that anatomy, it has not fitted into the ischium and ultimately eventually it will fail. At Arup Institute, we are proud that we have the robotic platform. So we plan very meticulously. We have a 3D planning software on the bone, and the robot guides us where we want to go. And the cup ultimately where it will be placed. To see in these cases where there is a lot of bone loss according to CT, this is what we achieved without doing much and placing the bone graft where we required and build out from the situation in a very good way. Thank you and have a good day.
Thank you, Dr. Aziz. The next speaker, Dr. Nishikant, who will be talking about the femoral bone loss.
So thanks a lot for inviting me. So hip revision surgery is now a more streamlined procedure and a more effective one. So we have seen various advances for the vestibular side like high friction cup, durability cup. Similarly, quite a bit has changed over the femoral side and it's evolving. So I shall be discussing about how to manage the femoral bone loss in terms of arthroplasty. It's not moving. So I will take you through the challenging cases which I have encountered in my career and how I have managed them. So this is a case of simple fractured neck femur managed with a bifuroctoplasty at some other center, got infected, referred to some other center, did proliphartoplasty, that again got infected. So this was the experience. Came to me with a discharging sinus from the hip, lying on bed for last 1 year. So decided to do it in 2 stages. After the first stage, I was left with this. So you can see the metaphysis is deficient, the diaphysis is compromised in the background of osteopenia, and I have to reconstruct it. So our goal is to achieve a long-term internal fixation, restore the bone stock, equalize the limb length, and provide a stable hip. So I came out with this. This is a reed stem, the long diaphyseal fitting stem with a constant cup ahead, and this is a 5-year follow-up. So we all are aware of the Paprosky classification over the vestibular side, but Paprosky has given a classification over the femoral side as well, depending on the location of the bone stock, whether it is metaphysis or diaphysis, amount of bone stock remaining in the proximal femur, and amount of diaphysis remaining for the diaphyseal fixations. So type 1, there is minimal bone loss. Type 2, bone loss is limited to the metaphysis. Type 3A, bone loss is from the metaphysis and diaphysis with at least 4 cm of isthmus remaining for the diaphyseal fixation. Type 3B, less than 4 cm of isthmus remaining for the fixations. And type 4, where most of the metaphysis and diaphysis is lost and there is no isthmus is there for the fixations. So what the options we have? We can either use the uncemented stem or the cemented stem. With the cemented stem, we have to use the impaction bone grafting technique, which is very challenging. With the cementless stem, we can have either the cylindrical stem or the tapered stem, which can be either modular or non-modular, or we can use the tumor prosthesis. So femoral impaction bone grafting is very challenging. You need to impact these allograft chips into the femoral canal with increasing tapered diameter of the rods. Then you need to negotiate a dummy prosthesis around the central wire to impact the bone chips around the cortex. Then you have to do the cement filling in retrograde fashion. Then you can put your prosthesis inside. So this is the case. Aseptic loosening with periprosthetic fracture. Managed with impaction bone grafting over the femoral side with this technique. So for the last 30 years, gold standard has been this fully porous coated cylindrical COCR diaphyseal fitting stems, the solution stems. But this has around 95% survival at the last of 10 years. But there are various complications like high pain, intraoperative fracture, stress shielding. Subsidence is very important in these kind of solution stems. So these are my own cases. This is a revision to arthroplasty. Decided to use the solution stem. So look at this. The intraoperative fracture. So these are very common. When you use these long stems, the 10-inch solution stems, these kind of scenarios are very common here. Another case, revision to arthroplasty for aseptic loosening of the AVN. At the 4th month, you can see the subsidence of the solution stem. I've used the largest side of the head, and the solution stem is well fixed at the diaphysis. So removing a solution stem is hell of a job. So how to manage it? So just changed the ball and use a neck adapter called BioBall, and this has been working since last 5 years. So, if you look at the survivorship of solution stems, around 5% mechanical failure at the 10 years. But most of the failures are in the 3B and 4. It has risen up to 30%. So what are the options we have? Either use cylindrical COCR stems or the tapered fluted titanium stems, which can be either modular or non-modular. So my practice, I always use exclusively monoblock tapered fluted titanium stems where indicated. Early mobilization from the day one. Good proximal bone distortion in all the cases, and it works well with the ETO. Like this case, aseptic loosening with broken bipolar. It's a very common scenario in our part of the world. Had to do the ETO, managed with this tapered fluted stems with a dual multi-cup add. This is a follow-up. Another case, total arthroplasty done somewhere else, got infected. Came with this X-ray, had to revise in 2 stages. After revising, was left with this. So it's type 4. So I use this long diphysial fitting tapered fluted stems along with the plate augmentation. So if you look at the complications, the tapered fluted stems have less thigh pain, less incidence of intraoperative fracture, less incidence of stress shielding and the subsidence. So the revision surgeons across the globe have shifted to this tapered fluted stems. So titanium metals ensures the flexibility, the tapered stem ensures the axial stability, and the fluids provide the rotational stability. The surface finish ensures the bony on-growth rather than in-growth. So the workflow is very easy. You read distally and you just negotiate the proximal variable part to normalize the limb length. Then you dial your version. But it is more complex, more massive inventory is required. There is a problem with the taper junction. So can we take advantage of this tapered fluted titanium stems and eliminate the problem associated with mobility? Yes, we can. By this monoblock tapered fluted titanium stems like Wagner and reductor stems. They are less complex. So the workflow is you read distally, you read proximally, you put your trial in and put your real stem in. This will hardly take 5 to 6 minutes. But there are 2 prerequisites. This must have a reliable distal fixation to prevent any subsidence. And it has to be reproducible. Means your real stem should go at the same level where your trial is. So they are much stronger. There are different tapered angles. There are 2 kinds of fluids, the major and minor fluids. So there are certain cases, the failed proximal femur fixed stem with the function of a knocking plate got infected, revised in 2 stages, use this Wagner stem. Other cases, aseptic loosening, ETO, revised with this Wagner stem. Another case, failed fixation, fracture distally as well, revised with Wagner stem with plate augmentation. So, does cylindrical stem have a role now? Yes. In type 2 and type 3A, we can still use the cylindrical stems, like in this case. Here, there is a Charlie stem got failed. Use this cylindrical stem, the solution stem. Another case, the isoelastic cup ahead. Use this Midas to remove the cement bits and use this solution stem here. So another case is a day 1 failure. Someone removed the screw ahead. The loss of bone loss from the proximal part had to be revise with this Wagner stem. So the multiple choices are available for tumor reconstructions. Tapered stems are user friendly and have less complication than the cylindrical stems. You can use this monoblock tapered or the diphysial fitting solution stems in type 2 or 3A, but for the type 3B and 4, you have to use this monoblock or modular tapered stems. Thanks a lot for your patient hearing, and I invite you all for our Patna Hipani conclave on 20th and 21st April. Prof. Ross will be coming there. Thank you.
Thank you, Dr. Mushikam. Nice talk. Now I'd like to request Dr. Anup Kumar to be speaking upon the ETO in DHR. Rule of ETO.
Good afternoon, Chairperson sir, and panelists. I'll be talking about the extended trochanteric for the facial stem. So my disclaimer is that I have some illustrative pictures from Air Foundation teaching materials. In a situation like this, when the stem has failed, patients need a revision to move about. So we need to remove this fixed stem, and to remove this we need to open a window and remove that fixed stem. And the indications of opening that window, which is the osteotomy, is a well-fixed cemented and uncemented stem, cemented mantle in septic and aseptic cases, and periprosthetic fracture in individual case scenarios. And if removal is failed of a failed component from its subsided or migrated position, would endanger the proximal femur, especially the possibility of fracturing of the greater trochanter. So there could be three options of proximal trochanteric osteotomy. So number three, the extended trochanteric osteotomy is our workforce, and which has the soft tissue coverage on it, whereas the standard trochanteric osteotomy and the trochanteric slide osteotomy would have. So TTO, the extended trochanteric osteotomy, was popularized by Younger in 1995, and this osteotomy facilitates femoral stem removal, and it reduces the operative time, complications, and many of the disastrous outcomes. The challenges faced by the surgeon is removing an existing component which is well fixed, or if it is loose, he needs to change it, addressing bone stock deficiencies or deformities, and solid fixation for a new component. So the steps of removal of an existing well-fixed femoral component would be access to the interface surface, and the cement may be well-fixed distally or even extended well past the isthmus. The cementless components may have extensive ingrowth surfaces and may be distally located, so which needs to be so working proximally to the femoral to perform distal cement removal or disrupt the ingrowth surfaces of a porous coated device may cause damage to the existing bone stock, leading to perforations to the cortex or disruption of the GT. Controlled cortical window at least initially weakens the remaining distal bone, and it necessitating use of prosthesis extending well past the level of the old cement. The surgical technique here, lateral equipress position and posterior approach, as we do our hips in the posterior approach, and the advantage in this is we can extend it and we are versed with it, and so if required you can extend the incision also distally in case of any disaster like fracture of the distal part of the femur occurs. Muscular tendinous sleeve should be preserved, that is proximally the gluteus medius and distally the vastus lataris. The extent is the base of the GT to the distal tip of the stem area to the and this should be anterior to the linea aspera and preserve the vascularity, that is stripping should be very minimal. So in this case, after removing the proximal part of the broken implant, the stem, you can see the metallosis, severe metallosis there. Now we plan for the exposing the distal part of the femur and planning outside. And here we can take use of the CM also to locate the distal end of the or tip of the implant. Mark out the osteotomy site on the posterolateral femur with a cautery pencil and outline the osteotomy with a multiple drill holes with a narrow high-speed pencil burr or a drill bit. So we have both the options with us. We do and begin at the base of the GT in the sagittal plane and extend distally and just stay anterior to the linea aspera, that is very important. Osteotomy with the help of oscillating saw, high-speed pencil burr or the drill bits, that's important. You should have your drill bits sharp. And gently curve the osteotomy to preserve the stress risers anterolaterally at the distal end, which is the transverse tip. So you don't have a stress riser there. And when you are doing this osteotomy, you should plan it at 1/3 and 2/3 junction of the femoral circumference, and when you put your drill or you first pass the KY, it should be planned that it goes above the surface, so or it gazes the surface of the existing implant. And Now, once you have connected the drill holes, then you can just open the hinge of the osteotomy and the anterolateral hinge of the periosteum, and the muscle should be preserved. And do this with a broad osteotome. You need multiple broad osteotomes to elevate. Now here you can see that the muscle sleeve is intact, and we are elevating it with the green arrow shows the multiple. The muscle sleeve is intact. So after this, retract the osteotomy, perform the cement and or the cement removal under direct vision, and minimize the possibility of perforation. And a caution is there that during canal preparation and the component resection, apply a cable or a wire distal to the transverse osteotomy side, so that prevents extension of the fracture and help progression of the fracture. So here it is again, you can see the distal part of the broken implant, and a prophylactic SS wire has already been done on the distal part, and broken fixed part of the implant is visible. And this is the end result after you have tightened all your SS wires. So the complications are non-union rate is as described in literature, then by multiple authors it's about 1.2% rate, and the fracture of the osteotomized segment is the most common complication. The bone loss and perforation, fracture of the femur and devascularization is again the common complication. Some of the examples are a 60-year female operated 7 years ago, came with a cemented, done with a cemented bipolar hemiarthroplasty, presented with pain and limp in the left hip owing a fall. So we went in, did a osteotomy, HQ, and extended trochanteric osteotomy was done, and this is the post-op, immediate post-op picture, and after 6 months, this is the picture. The second case where 57-year male, DHR was done 10 years ago elsewhere and presented to us 3 months ago, and 3 episodes of dislocation in the last 2 years were there, and where close reduction were attempted there. But the last could be reduced, and for the last 1 year it was dislocated, and this was at the time of implant removal. You can see the cement applied. And the top was well integrated, so we could just change the stem and it came off. And this is a periprosthetic fracture, which was managed by removing the loose stem and doing bypassing the fracture site. So the take-home message to avoid pitfalls would be minimize soft tissue stripping, do not elevate the vastus lateralis, and do not expose the anterior cortex. Avoid 90-degree transition at the junction of the longitudinal and transverse plane, so it should be a curve, and apply cable and wire distal to the prophylactic wire. And thank you.
Thank you very much, Anup. The next speaker is going to be Dr. Ramakant Kumar, who is going to talk to us about periprosthetic fractures around the femoral stem. So over to you, Ramakant.
So good afternoon, everyone. I'm going to talk about periprosthetic fracture management around the It's a very important aspect of PHR. So this is the data from Indian Society of Hip and Knee Surgery that is showing the incidence of total hip replacement cases are increasing day by day, and so is the risk of periprosthetic fracture. So estimated risk is approximately in primary total hip is approximately less than 1%. And in revision scenario, you can go to 4.2%. And it poses a difficult challenge to manage because this profile of patient is quite different. They are quite old, osteoporotic. So it poses a very difficult challenge to manage. So whom to blame? Is the patient, is the bone quality, or is the implant, cemented, uncemented, or the surgeon? So I think all the 3 factors are equally important and equally responsible for this. So this is a very important study published in JBJS. These 2 studies studied the epidemiology of primary PHR and revision scenario regarding periprosthetic fracture. And they have come to an observation that it's the intra fracture which is more common. In primary scenario, the risk was 1.7%, while in the revision case, it was 12%. Uncemented stem were more commonly involved in fracture as compared to the cemented stem. In division scenario, it was the fully coated, followed by proximally coated, and then fluted tapered stem. Another important observation was in primary THR, intra-fracture were more commonly seen in females more than 65 years of age, while no similar age and sex incidence was observed in post-operative fractures. So sometimes surgeons-related complications are easily preventable, so we have to be alert and cautious to prevent it. So this is a case, 85-year-old male with a septic loosening and broken stem. So I did a standard ETO to remove the implant, and this is the trial stem it's showing. So what is doing that is hitting the anterior cortex. So we have to be very careful. You can use image intensifier to confirm it, whether your trial implants or remotes are going at the right place. So you can prevent the intraoperative fracture. So in this case, I have to change the plan to use a long uncemented stem. I have to switch over to a cemented stem. So alertness and awareness can prevent a fracture. Another important tip is bypass the stress riser. You have to bypass the stress riser, like in this case, IT fracture revised with a long Wagner stem. Fracture needs to be bypassed. Stress risers need to be bypassed, otherwise the fracture is supposed to be. Simple tricks like while reaming in reaming scenario, don't rotate your reamers by 360 degree. Once you rotate your reamer by 360 degree, it's going to cause a fracture. So reaming is very important. Take precautions. Simple precautionary wire, like Dr. said in the previous lecture, use of precautionary wire while doing ETO is very good. It prevents the extension of the fracture. So these are some technical tips which can help prevent fracture. So once there is periprostatic fractures, it needs to be classified, and for that we have Vancouver classification. So basically it relies on three facts: the level of the fracture, the prosthesis is stable or not, and the quality of the bone. IB fractures are most common; they constitute 80% of the total periprosthetic fractures. And the reliability and validity of Vancouver classification have been confirmed by multiple studies in the past, so there is no doubt on the reliability of the classification system. So the management philosophy in periprosthetic fracture is quite clear and quite simple. So if the implant is stable, then fix it. If the implant is loose, then replace it. These two simple management principles, but the decision is affected by the multiple factors, like the site and pattern of the fracture, patient age, functional demand of the patient, bone quality, and the experience of the surgeon. So this is a 65-year-old female, born 10 years old, after 10 years after index surgery, Vancouver type AG. The implant was loose, so the stem was unstable, and the cup was well fixed. So loose stem was removed, fixed with the distal fluting solution stem, and the circular wire of the GT was done. Another case, 74-year-old male, history of fall. History of fall, he had a periprosthetic fracture, type 3, type 3C, sorry, B3. Cup was well fixed, but I had to remove the cup because I had to revise the hole. Did the ETO to remove the implant, remove the cement. So this is the immediate post-op X-ray, fixed with a Wagner stem on the stem side and vertical inside glass wires. We have the immediate post-op, 6-month post-op. We have the 6-month post-op, and this is the clinical video of the same patient walking comfortably. Another case, 76-year-old female, history of fall, cemented bipolar was done, Vancouver type B2. Implant was unstable, so revised with solution stem, multiple circular wire, and uncemented cup on the external side. Another case, the 66-year-old male, cemented HRA was done, but he came to me with a history of multiple dislocations in past 1 month after the primary surgery and somewhere else. So we have the pre-op X-ray. I did Initially, I managed with cemented stem on the femur side and dual monolithic cup on the stabler side. It came to follow up after 6 months following the first fall. So this was again Vancouver type V1 fracture. Fixed it with plant over the stimul with a simple locker plate and multiple central wires. Sternum on post-op, fracture at heel veil, and patient is walking. 85-year-old female, uncemented bipolar, fresh fall, Vancouver type V2, plant was unstable, femoral side revised using long distance fitting, fully coated stem, and multiple inside large wire. The sternum was healthy, so it was left untouched. There is another aspect like adding a biology to your fixation. So it's a concept of a strut only auto allograft. So this is quite popular and quite commonly used. It increases the stiffness, restores bone staff, and it's recommended in type B1 and type C, Vancouver types. Here are some new surgical technique. This is docking nail technique. Although for type B fracture, type B and C fractures, where they have modified the supracondylar nail and they have docked it with the femoral stem. Although it's a novel technique, they have shown only few cases in their study. We need more data to use it as a regular practice. So there are multiple ways of fixation, multiple ways of revision, but the treatment should be individualized based on patient age and functional demand of the patient. So the ultimate aim is to adequate stability must be achieved. So this is a very important paper which has studied the biomechanical aspect of fixation, different kinds of fixation. So they have used multiple kinds of fixation like A, B, C and D. You can see 8-volt, 8-volt, dual plate. So what they have observed is the long stem revision in all the fixation and revision, that was the most stiff construct. If we compare fixation and revision, long stem revision was the most stiff and a strong construct as compared to fixation. So what they recommend is B1 fractures need to be treated the same as B2 fracture wherever that is possible. That is particularly important in the cases of comminuted fractures. Another observation was you must bypass, and long stem revision, you must bypass the fracture site by at least 2 cortical dia. That will give adequate stability and adequate fixation and adequate stiffness. And the stiffness of fixation, if we compare the different fixation method, then using an 8-volt plate, 10-volt plate and dual plate, they recommended that the ABSC, the increase in the stiffness from 20% to 120%. And C, that is dual plating was the most stiff construct, but they have advised to add a biological strut instead of a dual plate. So take home message is try to prevent if preventable. If the implant is stable, fix it. If the implant is loose, replace it. Try to bypass at least 2 cortical dia to achieve adequate stability. Each patient is different, treat accordingly, and try to add biology wherever it's required. Thank you.
Thank you, Dr. Ramakant. I think we'll go on to the next speaker, which is Dr. Shashikant Kumar. We're going to talk about 2-stage revisions in DHR.
Good afternoon, everyone.
So today I will be talking about two-stage resident THR management principle in case of periprosthetic joint infection. So prosthetic joint infection is one of the most challenging complications of total hip arthroplasty, and it is one of the most devastating complications to the patient. Patient may present with persistent pain, persistent wound discharge, or persistent inflammation in tissue around the implant, that is surgical site. So in consensus meeting of 2018, AAOS came to a diagnostic criteria, two major criteria and multiple minor criteria. So major criteria included two positive growth of the same organism on the standard culture and sinus tract communicating with the joint or visible prosthesis. Here it is important to note that single positive culture comes in minor criteria and two positive culture with same organism includes the major criteria. So for these PCI, one stage revision can be done, but prerequisite is that culprit bugs should be known prior hand. We have to explant the implant, do thorough debridement, put the proper prosthesis and give antibiotics. So indications of two-stage revision in total hip arthroplasty is significant soft tissue injury with inability to provide soft tissue cover, presence of unknown or multiple resistant organism, and lack of access to appropriate antibiotic or lack of appropriate expertise. So, optimal surgical approach for the management of prosthetic joint infection is undecided. However, two-stage approach has been considered the gold standard for its management. In first stage revision, we will do removal of in situ prosthesis, a thorough debridement of bone and soft tissue, and interval spacer is inserted and antibiotic is administered. In second stage revision, definitive reconstruction is performed once the infection is resolved. So first stage revision, removal of implant and all the cement. We have to remove even those cement which is hardly fixed, and aggressive debridement is the rule. It is the main key step of success. So an aggressive debridement of entire effective joint space, removal of any previous scar and fistula, and harvested tissue should be sent to histology and microbiological studies. Even extracted implants should be sent for sonication where risk of negative cultures are there. So copious lavage with normal saline, and once explantation and debridement is done, then remove all the sterile drapes and put the spacer. So antibiotic spacer is put to eradicate the late periprosthetic joint infection. Many commercially available spacers are available, however we can customize it inside OT. So function of a spacer is to deliver antibiotic, preserve the joint space, reduce soft tissue contracture and maintain range of motion throughout spacer, that is interval time. Local antibiotic in spacer releases its antibiotic through a process called known as elution. So local antibiotic concentration should be greater than the minimal inhibitory concentration for the pathogen throughout the spacer period. Otherwise there would be danger of recurrence and emergence of resistant microorganism, and antibiotics should not cause any hypersensitivity to the patient, hence perioperative sensitivity testing should be done. These antibiotics should be broad spectrum, water soluble, thermostable, and bactericidal at low concentration. Most commonly used antibiotic includes gentamicin, clindamycin, vanco, tobramycin, aztreonam, ampicillin, and ofloxacin. Hand mixed antibiotics elute better than vacuum mixed antibiotics. And when we are putting antibiotic in these spacers, we have to take care of their concentration as well. So in elderly patient where renal compromise is there, antibiotic dose should be kept low, because there has been reported incidence of renal failure with tobramycin and vancomycin in these renal compromised patients. And duration of this spacer period varies from 8 to 9 weeks, because after 8 to 9 weeks they stop eluting antibiotic and it may act as a foreign body. So most surgeons choose a spacer period of 6 to 12 weeks and a systemic therapy of 6 to 12 weeks after reimplantation. In interim period, antibiotic therapy should be given based on antimicrobial sensitivity. Where culture is negative, then empiric therapy should be given, and decision for duration of antibiotic is depending upon clinical progress of the patient, that is healing of all the wound, and normalization of the inflammatory markers. So in interim period, once signs and symptoms of infection get normalized, antibiotics are discontinued for 4 weeks and inflammatory markers are examined weekly. Once this remains normal, the patient and patient is clinically well, soft tissue is healed, then we go for second stage. In second stage revision, after the resolution of all signs and symptoms of infection and normalization of the inflammatory marker, and it is more important to have a descending trend of ESR and CRP rather than only normalization, and a negative needle aspiration if it's there, then aggressive debridement of both bone and soft tissue should be done to remove any residual infection, and high pressure pulsatile lavage should be done before reimplantation. Then a systemic antibiotic therapy should be given for 6 to 12 weeks after reimplantation. Few case examples: a 62-year male, persistent pain in right hip since 6 months, uncemented total hip was done 3 years back for fracture neck of femur, patient total count ESR and CRPY high, hip aspirate was positive for step 4 years. So in first stage, mobile cemented cup and cemented femoral stem with antibiotic was given. After subsidence of all the signs and symptoms and clinical parameter as well as biochemical parameter, second stage revision was done with the reimplantation of a cemented stem and cemented cup. Implant was removed with ATO and it was well fixed with cement. So second case, 62-year female, operated 2 years back with pain around the right hip since 6 months, all the inflammatory markers raised, and there was on aspiration positive culture, infected monoblock, bipolar heavy replacement arthroplasty was done. So explantation was easy as implant was loose and monoblock customized mobile antibiotic spacer was put inside. Once all the signs symptoms fall, then reimplantation was done. Third case, 65-year male with complaint of pain around hip and pus discharge. Just last slide. Infected monopolar cemented head arthroplasty. So first stage revision, spacer, then second stage revision. So my take-home message is that prosthetic joint infection is one of the most devastating and most difficult to treat complication of total joint replacement, and two-stage revision approach has been considered the gold standard for this PCI, and no antibiotic can outweigh extensive and thorough debridement. So debridement is the gold standard. It will decide the fate of the surgery. Before reimplantation, all clinical and bioclinical parameter infections should be silent, and if sufficient clinical expertise and experience is lacking, then one should not hesitate to refer this patient to well-equipped center. Thank you.
Thank you, Dr. Siddharth. Next speaker would be Dr. Swarnan Samantha. He will be speaking upon the first
session is going very late, and please keep in time.
Respected Dr. Namaskar, first and foremost thing, because we are being brought by these stalwarts in AO and the revisions and whatever we have learned by this giant person and all my dear friends, and the real honor. I peeped through in the knee scopy session also with the shoulder. Here also in the hip session I am peeping through with the shoulder. Okay, so I think Orun has considered me already. I am doing shoulder surgery. So I think nowadays the people, those who are doing with the totally bipolar or the beautiful lectures that we have listened from our colleagues, that the revision surgery hip is really a challenge. Then doing the reverse, even the total or the hemi also is a challenge for the shoulder, because it is a very unstable joint. Even doing the hemi for a shoulder, unless and otherwise that guy is not dislocating for minimum 3 months, we are not being very happy. So this is the only picture probably for the juniors. They will understand that if your reverse is going to be successful, your deltoid has to be functional, because deltoid is the liver arm. If you see the liver arm, the L2, then this liver arm is, the deltoid is going to abduct the thing, because its ball is on the other side. So classic indication is the rotator cuff arthropathy. All of the extended indications, but mostly we do for the rotator cuff. So do we know the anterosuperior escape? One, that is the supra and infra is gone, the head will come migrate towards the acromion and there is no space between. Basically there is a acetabolization of the your acromion. So I think this is a horrendous sort of X-ray. This patient came with a 4-part fracture. Somebody fixed with this sort of nail. Probably during our PD career we have seen this sort of nail in 90s. And if you see the AP X-ray, this will look more horrendous, and probably this is the case for John sir only. So, but somehow this case came to me, and you see the head is been absorbed, the nail is in different place, and if you do it, the CT scan is mandatory because unless another you do, and also you see that when you do this some sort of revisions, not only if you are doing a CT, rather to go ahead with the CT angio also because you know where is the artery. So all my hemis, all my total shoulders, all my reverse I do in beach chair. So this is the when you do the reverse or the total shoulder, please take the X-ray of the other side because you knew the height. And there are also some templates. Also, if you don't have the template, even with the simple ruler, you can measure from the medial cortex. You can know where your implant is going to sit. So this is the picture you see. This is more or less this guy was having with this more than 2.5 years. This is pseudoparalysis. There is no movement from the shoulder. So you see, so when you do this sort of reverse shoulder, you have to be very cautious because just like the hip, you have to have a 360-degree vision of your glenoid, and you have to debride. You have to take care of all the labral tissue, the triceps, the biceps, because unless you take care of all the labrum, you won't do the base plate, and the core problem is that once you even if you hit the base plate, the ball is not going to sit properly. Okay. Also, you have to take care of the dorsal and the inferior tail. So, so the classic deltopectoral people even go with the superolateral approach. I have been also seen people trained that way, but I have done with some with the superolateral, but still I find deltopectoral is the good one. Even you can see with the deltopectoral, you can see the glenoid 360 degree. Then you have to put the ball. There are different sizes. As you are doing a new surgery, because this sort of training is not there in many places. You have to read the literature. You have to handle with the instruments and implants, how to do the trial, how to sit the base plate, where your screws will go. Because your base plate, you have to fire 4 screws, and the base screw is which is going toward the coracoid and which is going to the lateral border of the scapula, because front and back screws are smaller screws. So you see now this is the trial. But how people ask me how you do the trial and how you know this is the length of your processes. There are 3, 6 and 9 of your lengths on the humeral side. Then how much you impact. There are cemented stems, there are uncemented stems. Now there are beautiful stems have come. When we started doing, only Tepu was doing the reverse shoulder. Now many companies are available. You have the modularity on this side. Then you can adjust with this is the yellow one is the trial one. So in this trial one you can see the height, you can check. When you check the stability, you check 3 things. One is how much is the tension of the deltoid, how much is the tension of the conjoint tendon, and how much is the if it is front and back is going more than 50% or less than 50%. If it is coming more than 50%, then you have to change the height to 3 to 6 or 6 to 9. So you see, once you have done that, once you have put the trial, I will tell you that it's better to take a CR shot. You see that with your trial, you are basically hitting the proper glenoid, because when you do this sort of reverse shoulder, the problem is the glenoid bone stop. You have seen we have read the G1's classification. Even now from C the classification is extended to the D, but we have to have the CT scan to understand the scapular, where is the scapular spine, where your central peg will go, where the screw will go, and we don't have the facility to have now the facility has come in India that you can have your 3D template. So this is ultimately when you do it properly, you will have a good looking, proper looking and well fitted humeral head and stem. And I think you have to understand you have to read the literature properly, otherwise because Even for the hip, like your hip, it has to be properly inclined. The varsal you can play with on the humeral side, because ball is there on the glenoid side. This is real ball. You cannot change the varsal on the ball side. It is only the inclination. But the retrovarsal, how much you calculate for the same retro, you cannot put like your total shoulder. So I think you read the literature properly, and if you read it, and if you have the proper exposure, it's not at all a very difficult surgery. And the problem with when we started doing, people talked about how much is your notch. Always take care of the notch on the glenoid side. So goal is this: the fracture. It is a different ball game, and you have to resuture all your tuberosities. So read the manual, play with the instruments, be meticulous. Thank you very much for your time and patience.
Thank you, sir, for your nice talk, sir. I think the last speaker from session would be Dr. Ajay Singh, and he will be speaking upon the vestibular fracture paralysia.
So my topic for discussion for today is total hip replacement in vestibular fractures. So the question comes why? Why THR? When the open reduction and internal fixation and both column fixation is still the gold standard, then why we should go for the total hip replacement in case of vestibular fractures? So THR should always be considered when there is presence of poor prognostic factors. Secondly, the mortality rate is as high as 10% the first year, especially in the bicolumnar fractures. And conversion rate is 25% in high-grade comminuted fracture. So in those cases, you should consider THR as a primary shot. So coming to what are the poor prognostic factors. First thing is inability to achieve an anatomical reduction, which is a must for open reduction and internal fixation. If there is involvement of posterior vestibular valve, especially when there is combination of more than 3 fragments, when there is involvement of the superior dome and there is marginal infection, it leads to early osteoarthritic changes. Vestibular impaction is also a poor prognostic factor. Severe femoral head cartilage damage, especially in the weight bearing area. Neglected dislocation, which has the high chances of AVN. Highly comminuted fractures and elderly patient who are usually not fit for the fixation of both anterior and posterior column. So these are the classical indications for which we are doing the THR. First is the post-traumatic arthritis, non-human, malhuman and displaced head or neck fractures along with the vestibular fractures. So if you see the timing, it could be acute when we do it within 3 weeks. It's delayed from 3 weeks to 3 months, or it is delayed when we are doing it more than 3 months after the fracture. Now the radiological assessment, first we need to do the radiological assessment, first by the X-ray, epilateral and judicial, and the CT scan with 3D reconstruction to see whether it is whether the open reduction is better or the THR is better. So what are the challenges when we try to do the total hip? First thing is distorted anatomy. The anatomy is grossly distorted in cases of, especially in comminuted fractures. There are multiple fragments. Acute or chronic pelvic discontinuity could be present. There could be the bone loss which needs to be managed. Previous ward wears, if we are doing in a delayed cases, and chances of infection. Even in primary THRs, the chances of infection is more than when we do in the normal cases or osteoarthritis cases. In cases of vestibular fractures, incidence of infection is much higher then we look for the primary THR in osteoarthritis or the indications. What is our surgical goal to do THR in vestibular fracture? First is to get a stable fracture fixation. If you don't get a stable fracture fixation, your implant is bound to fail. Restoration of overall vestibular shape. Here we have to achieve the overall shape of the acetabulum, not the anatomical reduction is must. Both the columns should be fixed and stable. Either you do it with the plate, you do it with the cup, or either by either way. Stable acetabulum component in correct orientation, as it is the primary requirement in any PHR. Partial alignment approach is the most commonly used approach for the fixation. Reduction is done both column anterior posterior, and the column should be stable to collect the cup. Restoration of acetabulum shape is must. Sometimes there is a loss. You have the femoral head, you can implant in the area where the bone loss is present. You can cut it and place it with the help of screws and buttress it with the plate. Then do your rimming and trialing. Inflection bone grafting is required in most of the cases to fill the defect in the medial side. These bone grafts help early healing and it also stabilize the cup. Proper inflection grafting is a must. Do your trialing. Then implant of choice. The multi-hole porous coated cup is a preferred choice. It helps in the fixation also. This cup acts as an internal plate to fix the fracture. Cemented cup can be used in the delayed cases. Now screw placement is very important. Minimum 4 screws should be used, preferably 5 or 6, or you can use more than that. At least 1 screw preferably in the ischium and superior tunic rami. These screws act as kickback screws that they prevent the adduction failure of the cup. And other screws to get the primary stability of the cup. Primary stability of the cup is achieved by the screws or with the plate. Cemented cup with the inflection bone grafting can be done if we are doing it in delayed cases. Reconstruction with the cage is sometimes used with the cemented cup when there is pelvic discontinuity or the bone loss cannot be managed. So this is the algorithm which is published in Total Hip Arthroplasty in acetabular fracture, published in Journal of Clinical Orthopedics and Trauma 2020. According to this, if there is acute presentation, patient is young, always consider fixation first if it is unable. In elderly patient, see whether the joint is at risk or the bad signs are present. Then go for the THR. If the bad signs are not present, joint is not at risk, consider fixation. If the presentation is delayed or conservative managed, if there is symptoms, then go with the fixation or THA. If there is no symptom, continue the treatment. If patient present with avian or secondary arthritis, then there is no question of only fixation, you have to go with the THS with the fixation. Coming to the cases, this is the recent case we have done. This is the commuter fracture of both anterior and posterior column. Patient was around 55 years of age, diabetic patient. He was explained about the chances of osteoarthritis, but he opted for the single stage surgery. So this is the immediate post-op, fixation and THR was done. It's 8-week fracture healed well, patient is walking without pain. Another case, it's a 1.5 month, patient present 1.5 months later. There was deficient posterior wall, THA was done. This is another case where the primary fixation was done very meticulously, but that led to the osteoarthritis. THR was done, this is a 6-month follow-up. This is another case. Here one of the screw was inside the joint, but we just pushed the screw inside and did the THR. This is an interesting case. The THR was done, and after 5 months, patient met the accident that leads to the fracture of the acetabulum. Here again the fixation and THR was done. So take home message, always consider THR in presence of poor proximal fracture. Fixation plus THR has better result in acute cases. And use multi-wall cup to achieve initial stability with screw till fracture.
I think since we are running so late, we are not going to be in a position to take any questions. Please discuss it amongst yourselves. And that brings us to the end of this session. And I'd like to thank all the speakers for their excellent talks that they gave during this session.
Thank you. We proceed outside for presentation mementos.
Sir, one group photo. Yeah, before lunch. भैया इसको ऑफ करो, फोटो खराब हो रहा है। ऑफ बस अरे फेस पे चमक रहा है।
चलो चलो जल्दी करो।
सामने सुन लो।
इनका मंडे को फैट एग्जाम है सर, आने वाले रत्नेश सर, आपका नंबर दे। सर आने वाले मंडे 10 बजे सर आ जाएंगे, तैयारी कर लेना है पूरा, केस रखते हैं। चल একটা যেটা একটা সফট স্পট হয়েছিল সকালবেলা থেকে কমে যাচ্ছে, এটা যেমন 0 to 80 আছে, but there is redness, there is classic silence. Just after earlier, 1.5 months. Infection of the একটা হচ্ছে, we cannot identify the path. Then he gave he has to use IV antibiotic with Jolene and cephalosporin. MRI there is only subcutaneous plane joint কিছু নেই, only there is huge changes on the subcutaneous and the fat plane from medial to the local হতে পারে, localize হতে পারে, সেটা ওটা তো এই ডায়াগনোসিস ওপেন করে তো রেফারেন্স করে দেবে।
Slides not moving. In elderly, we are having the proximal nerve structure is difficult to manage due to poor thermal conditions. The mirrors, that is the minimal invasive reduction of osteosynthesis, is a new technique pinning that allows the correction of angular displacement and stable fixation in case of proximal nerve structures. Few to poor part of proximal nerve structures either can be treated by the mirrors or traditional percutaneous pinning method. Mirrors consist of 25 mm thick and 50 cm long stainless steel or Lizaro wire, which connected with the chest joint link that is tightened to lock the wires. The patient, after position in the supraclavicular level, patient in supine position with the head raised to 30 degrees, Before introducing the wires, attempt was made to reduce the fracture by manipulations. First K wire was introduced from the greater tuberosity towards the lateral epicondyle. Second, from the largest part of the head to the medial epicondyle. To avoid the subchondral impingement, these K wires are bent slightly after they had been reduced perpendicular to the skin. You can see the two proximal wire that is inserted from the proximally to the towards the medial and lateral epicondyle, and remaining two wires inserted from the proximal metaphysis from cranial direction until it reaches the subchondral bone, and further all these 4 K wires are bent to lock the external clamp. Once the clamp is blocked, it is possible to correct the varus or varus deformity position of the humeral head by compression or destruction of the wires. Then these wires are cut and screwed inside the clip with tightened post-operatively, and the sealing was given. Mirrors that remove after the 4 to 6 weeks. While in the traditional pinning methods, we use the wires as similarly the 2 wires goes proximally from the humeral head from the greater tuberosity, and 2 wires go cranially to the heads. In this case, we do not have the locking and reduction of the fractures after the positioning of the wires. So in the normal K wire positioning, we can see there is the movement. The wires go inside the joints. And that might be possible of moving the wires inside the joints, and this is the final X-ray in traditional percutaneous spinning methods. While in the mirrors, that is similar to the traditional pinning method, which close reduction percutaneous, but it is turning lock with the hinge joint and having the less complication as compared to the simple percutaneous spinning. Depending upon the degree of stability, active mobilization of elbow can be done, and passive 20 to 30 degree of abduction and forward elevation of the limb can be done. While in traditional pinning method, we have to we have to immobilize the shoulder joints, and which is also removed after 5 to 6 weeks. So this is the case of the mirrors. We have done the 2 proximal wire and the 2 wire from the humeral head and 2 cranially, and after that, which is externally joined by the hinge joint, just joint, and patient can be mobilized immediately. This is the another case which is fixed with the mirrors, and patient can be mobilized immediately post-operatively. This is the another case of the proximal humerus structure, which is fixed with the mirrors and which is externally joined by the hinge joint. This is the case of the mirrors fixation, which is in poor general condition we can use these techniques. The complication similar to the other techniques, that is vascular necrosis, non-union, malunion, post-traumatic stiffness, infection, heterogenic such as inadequate reduction, incorrect position, heterogenic bone formation, and impingement. Thus, conclusively, these mirrors result in better clinical result and less complication than traditional pinning in elderly patient. This method, however, is not indicated for the young patient with good general conditions. Thank you.
Thank you, sir. Now we would like to invite Dr. Neeraj Narayan Singh, sir, for presenting a talk on management of type 3A sine flaw disease by vascularized bone graft. Dr. Neeraj, sir. He is not available. We'll move on to the next talk, please. Dr. Swapnil Pedarshan. Dr. Swapnil Pedarshan. Dr. Arnav Sinha.
Okay, Dr. Arnav Sinha is going to speak on is TB gold, use or misuse of TB gold test for the diagnosis of TB spine.
Good afternoon, everyone. With permission of the chair. The gentleman who coined the term TB gold was probably a marketing genius. Why do I say this? Because slide please. Slide. Okay. because in management school we learned that when we are choosing a brand name, any brand name should be memorable, it should be distinctive, it should sound natural, it should be concise, and most importantly, it should evoke vision. So, TB Gold is a brand name which qualifies for all these criteria. And in the days when times we are staying, the patient calls the laboratory, he gets the blood test done from home, he delivers the result at home on WhatsApp itself, thereby bypassing the clinician and bypassing the doctor. And you talk to your pathologist friends, you will come to know that doctors, us, are also prescribing these tests routinely. So, orthopedic surgeons are prescribing this test, chest physicians are prescribing, then general physicians are prescribing this test. So, how did this test come into being? The principle being in patients infected with mycobacterium tuberculosis, the white blood cells release interferon gamma in response to contact with TB antigens, and the results are based on the amount of interferon gamma that is released. Sounds familiar? This is actually an updated version of the TST or the Montoux test. That is a century-old TB skin test. How many of us do a Montoux test for the diagnosis of spinal tuberculosis? I think nobody. On May 2nd, 2005, it got a final approval from the US FDA. It targeted two proteins, that is the early secretory antigenic target 6 and the culture filtrate protein 10. And in July 2005, the CDC convened a meeting of consultants and researchers with expertise in the field to review the scientific evidence and clinical experience of when to use a TB Gold test. What did they recommend? They recommended that it may be used in all the cases in which a TST is currently used. Simply put, जहाँ हम लोग Montoux test करते हैं, उसके जगह पे TB Gold test करना है, इसका और कोई रोल है नहीं. Including contact investigation, evaluation of recent immigrants, and sequential testing surveillance program for infection control. The benefit of TB Gold over a TST is that it is not affected by prior BCG. It has got low reader bias. How do you interpret the rest? The test? If it is positive, MTI, that is mycobacterium tuberculosis infection, is likely. If it is negative, then it is unlikely. If it is indeterminate, then uncertain likelihood of MTI. Borderline, which is present only in the TB Gold plus test, uncertain likelihood of MTI. For those that may have TB, either active or passive, the QFT blood test will either check the concentrations or the total number of producing cells. But the positive results do not necessarily mean that there is an active or passive TB infection. It simply increases the likelihood that an individual has been exposed to TB at a certain point of time. Now, in an endemic country like ours, it is said that all of us have had TB infection at certain part of our life. What is the efficacy? This is probably the only literature I could find where it was used for the pre-op PD of spinal TB. It said low specificity was a problem. It questioned the diagnostic efficacy and also questioned the intensity of this test. What about other mycobacteria? Of course, it is absent from the BCG vaccine strains, but it is present in the M. kansasi, the M. sclusi and the M. magna. And this report says that a positive quantiferon TB Gold test in a patient with Mycobacterium kansasi infection. In children, there are not enough data in children to evaluate its role in suspected active tuberculosis or suspected latent TB infection. For active TB, there is no solid grounds to prefer either the TST or the IGRA test over each other when it comes to predicting whether the infection will progress to active TB or not. Neither can it be used to diagnose active TB disease, nor for the diagnostic workup of adults suspected of having active TB. Now the question for latent TB, can it be useful in the diagnosis of latent TB? Latent TB has to be diagnosed according to the CDC by the exclusion of active TB, which can be done by signs and symptoms, by radiograph, either sputum sample or the clinical sample, and epidemiological information. Now what next? Even after that, if you try to do this test and it comes positive, what are the guidelines? Either you do the skin test or you do the interferon gamma release assay. If it is positive, can you guess what is the next test which is recommended? It is a simple chest X-ray. Now we should sit and understand that why not do an X-ray at the first go itself if we just want to do the screening? Which is more easier, more affordable, more practical, more readily available? X-ray or a TB Gold test? Of course an X-ray. Literature says there is limited data in the use of less than 17 years of age. Now that takes away a huge chunk of the patients. There is limited data in the recent exposure to MTB. Our country, we are an endemic country, probably everybody has been exposed to TB at some point of time. Limited data in case of diabetes. Our country is soon going to become the diabetic capital of the world. So what is the use of TB code? Then patients are immunosuppressive states like HIV, immunosuppressive drugs, corticosteroids, TNF, alpha, amphetamines, and there is limited data to determine who is at risk for developing TB disease. Now this is a unique problem which even the WHO would not have thought about. This patient, he refused proper investigation because clinically it was positive negative TB. X-ray was suggestive, TB code was negative. He got a TB code test done somewhere and he was very possessive of that test. He refused an MRI, refused histopathology, refused gene expert. He was not ready to get any further test. पेशेंट का ये कह रहा था सर हम टीबी को जांच कराए हैं उसमें नेगेटिव आया है तो हमको टीबी हो नहीं सकता. Now you cannot argue with that kind of a patient. So the delay in diagnosis, delay in initiation of treatment was 9 months. Thankfully the patient improved. This is the MRI 0 months and 12 months. So we have to remember that the hierarchy of evidence for the diagnosis of TB spine is still the same. On top is culture, followed by molecular testing, followed by AFP demonstration, followed by tissue reaction proteins, and the bottom three are what we commonly use, most commonly, radiological, physical examination and therapeutic response. The issue that medical providers face is that multiple negative IGRA tests cannot specifically exclude TB. Now India's diagnostic landscape was abruptly disrupted in the June of 2012 when the government of India, acting on the WHO 2011 policy against serological testing, banned the use, the import, the sale, the manufacture of antibody-based blood tests for TB and discourage the use of tests like TB Gold for active TB. But all of us know, if you look around, it is available in all the pathology labs, so it is banned, but it is available, and especially in people who are staying in Bihar, we know, and especially for people who are staying in Bihar, we know that some things are banned, but still available. Thank you.
Thank you, Dr. Anna, for nice talk. The next talk is by Dr. Vishal Singh. He is going to talk about the results of vacuum-assisted closure therapy and treatment of profound fractures of bone.
Good afternoon, everyone. I am here to present results of vacuum-assisted closure therapy in the treatment of compound fractures of long bone. This study was done to assess the efficacy of topical negative pressure wound dressings as compared to conventional moist wound dressings in improving the healing process. It is used as an adjunct or alternative to surgery for a wide range of wounds with an aim to decrease morbidity, cost, duration of hospitalization and increase patient comfort. The practice that wounds should be kept dry, although still held by a considerable number of clinicians, is steadily losing ground. We have calculated that wounds develop granulation tissue faster when treated with moist wound dressings. Air-sealed packing of wounds does not lead to infection. Recent studies have shown that maintaining a negative pressure in a controlled manner to the wound site helps in wound healing. Agenda and Seattle presented the original description of negative pressure wound therapy. Now, mechanism: the compression of tissue by negative pressure causes tissue hypoxia due to decreased perfusion beneath the foam, which stimulates angiogenesis and local vasodilation due to the release of nitric oxide. This occurs during the suction off period of vac therapy. Therefore, intermittent mode of vac is more effective as compared to continuous mode. This study was done as a prospective randomized controlled study to find out outcome of efficacy of vac to conventional moist dressings. And application of wax dressing needs the following materials: QT cell and a pair of radon drainage tube with suction involved. A fenestrated tube is embedded in the foam and wound is sealed with adhesive tape to make it airtight. The fenestrated tube is connected to a vacuum pump with fluid collection container. The machine delivers continuous or intermittent negative pressure ranging from 50 to 125 mmHg. The wax dressings are changed on third day. The position of tubing is away from bony prominences. Intermittent mode consists of a cycle of 5 minutes on and 2 minutes off phase. The pressure setting can be kept low, 50 to 75 mmHg, particularly for painful chronic wounds. For chronic non-healing venous ulcer, the optimal pressure is 50 mmHg at intermittent cycles. Higher pressure, 150 mmHg plus are used for large cavity and exudative wounds. Acute traumatic wounds require negative pressure of 125 mmHg. Negative pressure of 125 mm of mercury is considered as an optimal pressure. This study consisted of 30 cases and inclusion criteria was wounds caused by trauma with soft tissue injury, post-op and surgical wounds with exposed bone, fasciotomy wounds in compartment syndrome. Exclusion criteria was non-cooperative patients and patients with malignancy, bleeding disorders and patients on anticoagulants. Results and discussion. It can be used in management of both acute and chronic wounds. Wax stimulates wound healing through two processes called macrostrain and microstrain. Macrostrain draws the edges of the wound together, equally distribute the negative pressure and removes exudate and infectious materials. And microstrain reduces edema, stimulates perfusion and stimulates granulation tissue formation. It was first proposed by Argentina and Morris in 1997. This study includes patients aged ranging from 20 to 80 years and mostly in patients more prone to accidents like laborers, drivers, etc. The sex ratio in male to female is 1.5:1, showing male dominance due to male exposure to more stressful situations. The total hospital stays for patients for a mean period of 32.5 days, which is significantly less than a standard other modalities followed in normal practice. Vacuum therapy is contraindicated in patients with malignant wound, osteomyelitis, fistulae to organs or body cavities, and those with exposed arteries, nerves, and anastomotic site. And we concluded that wax therapy may be used after the debridement of wound because it decreases wound edema and enhances the formation of granulation tissue. This wound is easily healed by secondary intention or can be managed with a simple skin graft or flap. Without the wax, this wound might have required to be treated with a pedicle or microsurgical free flap. The results of grafts are also better in cases of wax therapy. Duration of hospital stay was reduced in the wax therapy group. Wax, however, is technically more demanding. And complication of wax therapy includes failure of wax system like loss of seal, power failure and blockage of the drainage system. Pain, bleeding, allergies to the adhesive drape, restricted mobility, adherence to the tissue to the foam. Air leaking dressing should be avoided as it leads to continuous flow of air over the wound surface, leading to desiccation of tissue and formation of eschar. This eschar seals the wound with retained exudate and leads to worsening of the wound. Thank you.
Thank you, Dr. Amit. And thank you for finishing right on time. The next talk is by Dr. Mithilesh Kumar. He is going to talk about compound fractures of long bone managed by titanium elastic nails, 10 cases.
एक मिनट लगा दो।
Thank you, Chairperson. My case is compound fracture of long bones managed by titanium elastic nails. Tells as definitive fixation. It is minimally invasive process based on sound principles. Poor patient cannot afford repeated surgery. Can start early weight bearing also. Compound tibia fracture. I have taken tibia because tibia is most commonly fractured compound. So 43 cases, all united, segmental 4, gross combination 5, male-female ratio 3:1. Now within 48 hours, patient came within 40 hours, within 1 week 41, and after 3 weeks 2. Final primary median 39. 4 requires bone grafting and pedicle flap for prolonged infection. Principles are same as in pediatric patient. The first case, compound with butterfly fragment, 2 pre-contour TENS applied, patient recovered. Comminuted shaft fracture, 4 shaft is comminuted. Here 3 titanium TENS is applied, and skin is healed, and bone is also well united. Skin condition was poor, pus was coming out, result below. It is 4-week-old case. This applied titanium elastic nail, but later on sequestrated bone, removed and plastic procedure done. Another case of Elizaro and X-Fix, poor patient, applied 2 TENS, dressing and kept in slab. This is clinical picture, wound healed, and bone is also united. Another case, titanium nail. Another case, principles are, there is no time. So this mechanism is, it is flexural. It produces flexural stability, transitional stability, axial stability, rotational stability. This is how to done. The another case is segmental. It is case done in 2016 when earthquake had come. I have done it 3 days. Earthquake के 3 दिन पहले मैंने इसे किया था, और जब earthquake के बाद इसे देखा कि he is standing outside without support. So I asked him for immediate X-ray. This is his operative picture. This is after X-ray, and I did not apply any slab, and he was walking, and this is union. Another case, it is also united. This is lower third fracture, but when this grade 3 compound, 3 weeks old, came from outside, communicated. Here we applied 2 TENS, wound healed, and later on we did interlocking nail. That X-ray is not present. Another case is also healed. Titanium nail extracted. Next, compound segmental fracture fixed with 2 TENS, but after initial wound healed, INL was done. Here we see the 2 nails, but the diameter is different. So bone. So we removed it after healing of wound and applied INL. This another case is segmental fracture, long segmental fracture. Applied 3, and it is united well. This is clinical picture. He is moving, doing everything. The gunshot injury come back from the hospital, government hospital. Extremely poor widow of middle age. This is the X-ray. Now we just have discussed. I have done this clinical picture, operative picture, This is done to elastic nail. This is few months after. This is how it is done. And nail is removed. Patient is all right and doing his all work. He says field worker. वो मैंने घास वगैरह करती है इस तरह से. And another case, this I have kept to show how this is done. This compound and two elastic nail is applied, and later on it healed perfectly. Wound is primarily closed. With same principle, other long bones like compound fracture of femur, humerus can be treated. Few cases, it is a fracture of humerus, proximal humerus. This clinical picture, it was compound and two nails beautifully united it. And another, this is fracture of femur, compound. One part of is lost in field, and when we applied this titanium elastic nail, the cortex start to develop from that side which side the bone was lost. It is this is done previously. Wound healed, and this is its final picture. One case, the compound, when I put iron nail, but it failed. Another case, we applied to elastic nail and it healed. So, advocated as primary fixation implant for use in compound fracture of long bones, especially tibia. It is our take-home message. Thank you all.
Thank you, Dr. Mithil, for delivering a lovely talk. Now I invite Dr. Indranjeet Kumar. Is he here? No. So we move on to next, Dr. Vidya Sagar. He is going to talk on functional outcome of total hip replacement in tubercular arthritis of hip.
Yeah, good afternoon everyone. So I think this is the second last topic. So my topic is functional outcome of THR in tubercular arthritis of the hip. So the THR is a very common procedure, and in tubercular arthritis of hip joint is involved almost in 10 to 15% of the hip joint. It usually affects the synovial line, cartilage, bone in the joint, and result in progressive destruction of the joint, causing pain, stiffness, and disability. There are several challenges in the management because of its complex nature and serious complications. There are few options rather than THR like arthrodesis or external arthroplasty, but these have several disadvantages. So the THR plays a crucial role in the management of TB hip, particularly in cases where conservative management fails to prevent adequate pain relief. By replacing the damaged hip joint, restoring mobility, alleviating pain, and improving the quality of life. So the aim of the study is to study the functional outcome of THR in the tubercular arthritis. This prospective cohort study was done in adjunct for 3 years. We have included the patients which have initiated TB of ATT after 4 weeks at least, and we have excluded the patient with active sinus and HIV positive patients, and the patients who have taken less than 1 month of ATT. Clinical radiological parameters were taken, and functional outcome was used for Harris score, and all patients were underwent THR by modified lateral approach. Spin incision was done, and after reflecting 2/3 of the gluteus medius, head is dislocated and the neck was cut, and this is one picture of TB hip. And after that we have applied the 4 retractors, anterior, superior, and posterior and inferiorly, and after that stabilizing was done, and first in all the cases stabilizing was done first, then the femoral broaching was done, and final implantation like this was done. So 23 patients were reported in the study, and minimum follow-up was at least 1 year. And demographically, we can see that most of the patients were of younger age group, and male outnumber the female patient. And coming to laterality, right hip was 11 and left hip was 12. ATT course initiated was in 9 patients, completed in 10%, and there were 4 defaulters. And in all the patients, the clinical presentation were like pain, deformity, in most of the cases flexion deformity, and restriction of the motion was present there, and most commonly the internal rotation, and there was limit testing. Mean degree of Harris score was 37 plus minus 4, and after 1 year it was around 88. There was 5 complications in which 4 was linear discrepancy and 1 case was superficial infection which hit after debridement. So what other literature said regarding this? This paper was published by Nagy et al. He showed that in the index study, 39% underwent the THA during active TB, who has been started on ATT for minimum 4 weeks, and no reactivation was seen. And in his study, Harris score was after 1 year, it was 86 to 97. Another study done by Nagy et al. The functional outcome of the patient improved significantly as the history of Harris score to 37 to around 90. So another publication was published by Rajesh Malkar et al. Regarding this. So to conclude, THA is safe procedure of providing symptomatic relief, functional improvement, and early preventive activity. Here are 3 cases. This one is a 50-year-old gentleman. You can see the tubercular arthritis of the hip joint, and uncemented THR was done. This was post-ATT. This another case is post-ATT 2 years, and he was having pain during walking, and uncemented THR was done. Almost 2 years follow-up, patient is walking comfortably. This patient is has suffered from TB around 30 years back, and current age is 67 years. And uncemented THR was done. Patient is walking comfortably, and this patient was suffered from TB in 1994. His current age is 44 years. Long back around as per uncemented THR. This also, and this patient was done. This patient was on ATT for 6 months, and bone infection, bone grafting along with multi-hole was done. THR was done. Patient is walking comfortably. Thank you.
Thank you, Dr. Vidyasagar, for enlightening us and also finishing before time. Now I invite Dr. Vaidyanath Kumar. He is going to talk about bilateral endoscopic surgery for PIVD stenosis.
Good evening. Our session is going to come to you. My name is Dr. Boacon. My topic is unilateral biportal endoscopic decompression for lumbar canal stenosis. I think this is totally a new era of surgery in spine surgery, endoscopic surgery. We are going to discuss some. This is also called as UB surgery. That is unilateral from one side. With 2 ports, we are doing endoscopic surgery. So basically, it is not a fully endoscopic surgery. In fully endoscopic surgery, we put the instruments to the same channel, to the endoscope and instrument. But in this case, UV surgery, we have 2 separate channels, one port for the scope and one port for the instrument. Actually, it is a very minimally invasive surgery, and it now can treat very wide variety of pathology like stenosis, PIVD, even foraminal stenosis, even fusion surgery. So, total 22 patients of degenerative lumbar canal stenosis with average age of 60 years, 62 years, between July 22 to 23, December 23 were done from left side in all patients, because for right-handed person, it is always you have to perform with the right hand. Instrument has to perform with the right hand. So in the left hand you have to take the scope, you handle the scope, and in the right hand you handle the instrument. So if you are ambidextrous, you can do from both sides, left side or right side. But beauty of this EB surgery, through unilateral, you can decompress other side also, which is not possible in full endoscopic surgery. So, just a proper workup, especially in anesthesia, we do it in the general anesthesia. So we are learning still. Then we are doing in the spinal, in the epidural, any anesthesia you can do it. So in position the patient in prone and adjust the table so that the lordosis will get corrected, and after proper antiseptic precaution from the left side, first to mark the interspinous line or mid-axial line. Then you mark the medial pedicular line, medial pedicle line. There are two important landmarks. You can see here. There are two important landmarks. One is mid-axial line, interspinous line, and the medial pedicular line. And in the medial pedicular line, that we give the two incisions, one for endoscopic, especially the transverse incision. We give the transverse incision at the endoscopic portal for endoscopic portal, and other for the instrument portal. And the length of these two incisions is almost 3 cm. So incision with the number 11 grade. And the important thing is, before putting the incision, you just take the 16 gauge needle and try to triangulate it at the spinal minor junction. And then you incision is given and cut the fossa and along the middle. And basically endoscope, 5 mm endoscope, 30 degree or 0 degree. I am using 30 degree endoscope, and working portal is little bit wider because you have to work with the instrument, spinal instrument. And the docking point is basically at the spinal minor junction of the cranial lamina. And it works at the same principle of triangulation as in any arthroscopic surgery. Or especially the docking area, where you, because in the spine there is no space, you have to create the space. You have to create the space, and that space you create is called Swan's space, because you divide by Mr. Swan, Dr. Swan in South Korea, it's Swan's space. You just have to, in the docking side, you just have to make a to and fro motion of the liver and create a space between the multifidus muscle, fibers of the multifidus muscle, or you can say the multifidus space. And this is the, you can see here, the triangle is there. This is the docking point. Especially the one with the actually EV surgery is water breathing surgery. So clarity of vision is very good. Or the important thing is through the channel, both the channel, input channel and output channel, first you create the medium so that the flow of the water is good. The minimum prerequisite for starting the surgery, your flow of the water should be very fluid from one portal to other portal. You can see it. And the basic UV instruments here like this, general instrument and some special instruments are there. And the two important things required in EB surgery are a plasma, probe and power reading. Or you can use a diamond burr or a sheath protected burr. And serial dilator and dissectors and extenders, then toming, correction and this course of instrument. So results were studies on the VASA score for low back pain and leg symptom. It has improved from 6+2 to 2+1 in the low back pain, and leg symptoms 7+2 to 1+1, and average hospital speed was 2 to 3 days. And one patient has mild dealer there which I kept it as such, no need to do anything. And one patient had transient motor weakness, maybe due to some mishandling of neural tissue or nerve root. You can see very good decompressions of the spine from both the sides. In MRI, you can see the good decompression of the nerve root. So complications are just dural tear, hematoma, root injury, inadequate decompression, and hypothermia. There is. At conclusion, it is effective in decompression of DLCs with minimal damage of soft tissue and facet joint, and it is possible to avoid fusion and preserve the segmental mobility. Thank you.
Thank you, Dr. Mehta. There is a new entry, and Dr. Ayush Kumar Sinha is going to talk about complex primary TKR. Dr. Ayush? No, that's not. So, one of our presenter is here, Dr. Neeraj Narayan Singh. He is going to talk about management of type 3A key box disease by vascularized bone graft.
Good evening, everybody. Myself, Dr. Neeraj Narayan Singh, Associate Professor at ESIC Medical College, presenting a case series of management of type 3A inbox disease by the vascularized bone graft. Yeah, everybody knows here. Inbox disease is a progressive disease which is caused by the avascular necrosis of lunate and leads to lunate collapse, abnormal carpal motion, and arthritis of the wrist, and leads to reduction in the wrist motion with the pain and swelling. And it is difficult to diagnose at the initial stage. The risk factor associated is negative ulnar variance and is peculiar blood supply and raised intraosseous pressures. Staging is by the Leachman according to radiological classifications. Early stages can be managed with the conservative NSAIDs or POP's cast. And with the patient can be the negative ulnar variance can be managed with the radial solving procedure, and for neutral or positive ulnar variance patient can be treated with the decompression procedure alone. In type 3 there is a lot of confusion, and so here the case can be managed with the vascularized bone grafting and along with the limited wrist fusion. That can give good results. In stage 4, we all know that can require total wrist arthroplasty. Here we have done 4 cases between 21 to 23. All are in the stage 3A according to Leachman classification. 3 were male and one was female. Average age is 35. All the patients affected with the dominant hands. Initially managed with the conservative management up to 18 months with NSAIDs and medications, but once there is no improvement, we went for vascularized bone graft. The pre-operative evaluation we take into account the symptoms, ADL, activity of daily living, and VAS scores. Wrist movement measured by the goniometer, flexion, extension, radial and ulnar deviation combined with the total arc of the wrist motion, and grip strength measured clinically, and pre-operatively the tenderness was present over the lunate and passive painful movement at wrist. X-ray we required is PA, lateral and oblique view, which made the forearm neutral, and we measured in pre-op and post-operatively, and MRI shows all the patients are in stage 3 disease. No patient had fixed rotator subluxation of the spine. Diagnosis is totally based on the MRI. And all the patients have carpal height ratio was reduced. We did under brachial block with polar approach, and we did pronator quadratus muscle pedicle, distal one-third pronator quadratus muscle pedicle graft, which is fixed with the absorbable suture. Post-operatively, this was immobilized for 6 weeks, and then physiotherapy was started. So here are the pre-op X-rays, and MRI shows the fatty degeneration, and we can see that there is no cartilage involvement. It is in stage 3A. This is intra-op picture. We localized the unit and we did vascularized bone grafting. After 1 year, this is the follow-up of one patient. Second patient, this is the muscle pedicle graft we did, and this is the range of motion. Results are classified according to both fair and poor. The good result, which good result was defined as long-term pain relief and improved function, and there is no additional treatment needed. Fair result was one in which pain relief was achieved temporarily, but ultimate additional surgical procedures were performed, and the poor result was defined as no significant pain relief or improved functions of the procedure. The pre-op and post-operative sample T-test was compared. For the pain, there is subjective pain relief in all the patients, which was statistically significant. Where patient exhibit increase in total arc of motion post-operatively, which is not significant post-operatively. All patients are able to return to work, but has limitations of lifting heavy weight. Radiologically, patient had no changes in prolapse, or there is no change in carbohydrates. So no patient progressed to stage 4 disease. So all this classification initially is based on the Leachman classification, which is divided into 4 stages. There is sclerosis, collapse, fragmentation, and arthritis. But nowadays there is a new algorithm has come, which is based on the Leachman and Pintka, or this new algorithm given according to the amalgamation of the osseous, which is Leachman classification, the vascular classification, which was given by the ischemic, and the cartilaginous classification, which is given by the Boacon. According to this, Bain classification is arthroscopic classification. It depends on which cartilage is involved, which joint is involved. Whether proximal lunate is involved, or proximal radiolunate joint is involved, is there fragmentation of the joint, is there capitolunate joint arthritis, or stage 4, all the joints have got involved. Smith depends on the bone marrow viability, whether it is normal, ischemic, or partially necrotic, or completely necrotic. So, according to this classification, patient presented with less than 15 years, more than 70 years, have good prognosis with the conservative management. And patient in the adolescent age group 16 to 20 years, or between 21 to 70 years, give conservative management. If it is failed, then comes to the look for the bone. Then Leachman classification, whether lunate is intact or not. If it is intact, do unloading procedure. It depends on the ulnar variance. If it is negative ulnar variance, do the radial sorting. In positive ulnar variance, do capitate sorting. If it is reconstructible, then if a functional articulation is present, then unloading and vascular grafting can be done. Otherwise, osteochondral graft. If there is along with the carpus instability, then we can look for the functional articulation, either scapucapitate fusion, proximal loop orbectomy, and the radioescaphoid lunate fusion can be done in advanced cases. Wrist fusion is the ultimate thing. And there are several papers which compare the result of the lunate offloading and revascularization. So more or less same results, but offloading and this article by there is one more article supporting these recent advances, which shows that stage king of 3 disease can be managed with the vascularized bone grafting. These are the new algorithms of the state of the inbox scans. Thank you, sir.
Thank you, Dr. Neeraj. That brings to end of the session. Now we are running late. Anybody has any question with any speaker?